Good morning. How are you? How was your first day yesterday? Good, good. Glad you're in the room? I'm glad you're in the room. We have a really power-packed day, and I think it's something for everybody. Be sure and look at where your options are because there's going to be some great stuff across the hall, too. We're going to try our best to stay on track time-wise because we have an amazing luncheon in here. And then some of us head to the White House to represent you right after lunch. And the rest of you watch what you want to see of the White House in here while we also have roundtables going on. So I want to explain that piece just as a housekeeping measure real quick. So we'll have some sessions this morning. Then we're going to have about 20 minutes where we're outside of the room so they can set the tables for lunch. Do your very best to make that happen for me, okay? And then we're going to come in, have a great lunch. After lunch, the live stream will be over in HJ at 2, from 2 to 3 o'clock. You'll see everything that's going on over at the White House. If you're like, I can do that later, then you'll be in here, and there's just going to be different round tables, 3 or 4 round tables going on at the same time. And then we have something for young adults in K. Your kids this morning, if you have kids that are upstairs, at 9:30, they're going to leave for, if they're in the younger group, the Children's Museum. They're going to walk across with chaperones. I made them promise to hold their hands and all that good stuff. And then if they're a little older, they're going to the Spy Museum. And then they'll be back on property after their lunch at 1:30. So if you're looking for them and it's empty, they're not kidnapped. They're just at a museum. And then they'll have some activities. We'll end up about 3:30 today. And there's a couple of things I want to draw your attention to for tonight, because we don't want you to be bored while you're here, for heaven's sakes. We don't want you to get too much rest while you're here. So some of you that were at ladies' night last night, was that fun? That was fun, wasn't it? How about the guys? Did you guys have any fun? Had a little bit of fun? Good. That's important, right? We do heavy lifts, and so we have to have fun together, too. So ladies, you met Marcel Cairo, who, is sharing like that consciousness survival medium. That's way outside our scientific realm that we know it. But it's something that many of you want to know more about. There's a poster in there that has a QR code. And if you want to take part in a session today, there's one as we wrap up. I think it's 4 to 6, and there's one tomorrow. That's small group. Marcel's very kind. Those of you that were with him last night, not scary at all. And then we also have from 5 to 7 out on Freedom Plaza, the Cure Fest welcome party that all of you are absolutely invited to. And then if you're a CAC2 member, from 6 to 8, that's Coalition Against Childhood Cancer. You can join as an individual. You can join as a foundation. That is from 6 to 8, a reception here at the hotel. And then the DIPG community, and we're just going to extend that. If you're a friend of the DIPG community, come on over. We're going to be at what is it? Astro Beer Hall. Okay. But they have everything you ever wanted. Donuts, chicken, and beer, all in one place. Oh, and old-fashioned video games. So, yeah, we do like to have fun. And that's from 7 to 10, and I think kids can stay till 9, if I remember right. So lots to do. We're happy you're here. And if you have any questions, you just come and ask. And please ask questions in here. Speak up. I challenge you to decide how you can make an impact in the next year yesterday. And I hope you're writing some notes down. So as you leave, you'll say, here's how I want to do it. And if you're not sure and you're like, I just want to help whoever needs help, you just stop at the registration desk and put your name down, and we'll put you to work, because there's always a lot to do. Thank you guys for being here. It means so much to us.
It is my great honor and privilege to introduce today's keynote speaker, Dr. Praveen Raju, who's an associate professor of neurobiology and pediatrics at the Icahn School of Medicine at Mount Sinai. He completed his MD PhD training in developmental neurobiology at the University of Pennsylvania School of Medicine, his pediatric residency at Columbia Presbyterian Medical Center, and his pediatric neurology fellowship at Boston's Children's Hospital, Harvard Medical School. He performed postdoctoral work at Memorial Sloan Kettering Cancer Center, developing mosaic mutagenetic approach in the mouse before moving into the setting up his independent lab of pediatric brain tumor research at Wells Cornell Medical Center. In 2010, where he was the Engeler Clinical Scholar in Children's Health. He was recently recruited to his current position in 2020, where he established and co-directs the Mount Sinai Children's Brain and Spinal Tumor Center. Dr. Raju is also the program director for the Pediatric Neurology Residence Program, as well as the associate director of the MD PhD program at Mount Sinai, and was recently chosen to serve on the NIH-funded NIH-funded Child Neurology Career Development Program and Advisory and Mentoring Committee. In addition to his clinical and educational endeavors, Dr. Raju has directed an NIH-funded translational mouse genetics-based research lab focused solely on pediatric brain tumors over the past 15 years. He has been recently working on a novel nanoparticle based drug delivery approach to bypass the blood-brain barrier in order to improve outcomes of children and minimize the treatment's side effects. In addition to that, he is going to give a phenomenal talk. He's going to address the elephant in the room, which we are all afraid to talk about. So please give a round of welcome to Dr. Raju.
Thanks, Misha. No pressure, right? It's so nice to be here and for the opportunity. I've been in the field for about 15 years independently, and I'm not that young, but I'm not that old. But 30 years ago, when I started medical school, if you asked me would I be either a pediatrician, work on the brain, or work on cancer, the answer was no to all three. And it was only my experiences when I was a resident seeing children with brain tumors and spinal tumors that really showed me there was a need. And you'll see kind of a history of what I do, and kind of over the course of the 15 years. And even though we've learned a lot, I would make the argument that we need to do a lot better, and we haven't done as well as we should. And hopefully my goal here is to be informative and educational. At times, I might sound critical and controversial. The goal is not to be that. It's to be that hopefully we can use these controversies to do better. Okay, so let's start there. Spent probably more time on this slide than anything, so I'm glad it actually worked. And this is basically the blood-brain barrier and how we're going to get things across. As a disclosure, I kind of do things on the clinical side and on the lab side, but I think as many of you know, to get drugs into kids, we have to work with industry. And so we started a company. And so as a disclosure, when you have a technology and you talk to industry and they said, why do we use it for this and that? Well, I think the advantage I hope I can use is that since I work on brain tumors, I can control what we can use this technology for. And I'd like to focus it on DIPG and Benjulo as a start. So, translational issues we'll talk about, and I think you'll see them come through. And I think in those of you who have children who are actively in the fight against pediatric brain tumors or were in the fight, I know many of you have been 15, 20 years, I heard yesterday. I think the real key is you've heard a lot of these things. You heard about the next big thing. Carl Koshman yesterday said something like, 5 years ago, this looked great. We just haven't gotten it to the clinic. So you hear a lot of great stuff, and why is that? And I will try to tone it down, because I don't know if Adam Resnick is here, but he did say something to me that he had a dream about me. A true story yesterday. And it was me with wearing a shirt that had Selectin on it. So I'll try to tone it down, but but it's hard for me sometimes. So we'll talk about this delivery system. And I think the blood-brain barrier is a barrier. It's a hurdle. And I think you hear about this in all kinds of cancer, and importantly in pediatric cancer and peds brain tumors, is we want to get better drugs, make them more efficacious, and make them less toxic. A lot of talk, but I'll tell you how we kind of do this realistically, and you're wondering, wow, that's really toxic. Well, maybe there's ways we can change that. I didn't go back. There's hurdles. They're all elephants. Most researchers, most clinicians, and probably families know these hurdles. Many of your foundations probably evaluate grants. These hurdles are there, but if we keep ignoring them, and of course, if we keep ignoring them, they're just going to get bigger and bigger and bigger. And I think we have, and I'm going to make my first controversial comment, which is I think we actually have a lot of good drugs. They just may not be used the right way in peds brain tumors, maybe not used effectively, but they're good drugs, great scientists, great pharma companies. But if we can't get it to where it needs to work, maybe that's the problem. We certainly need more drugs and better drugs, so I don't want to diminish that either. So these are the hurdles. You've heard of these terms. Dr. Martis yesterday and others have talked about heterogeneity. So we'll go into what these are, but in the context, and again, pick your favorite tumor that you study or your unfavorite tumor, unfortunately, if you've been affected by it. DIPG, DMG, medulla, whatever. Every cancer cell is not the same. In a tissue culture dish, maybe they are. So easy to treat, and I can put bleach on there, but if you can't put bleach in a kid, because it's toxic, that's a problem. DMG and DIPG is a metastatic disease. We think of it as localized, but the data is 10 years old. From 40 patients' post-mortem autopsies, the tumor is way beyond the pons. So if we're only going to study the tumor cells that are in that pons, granted, any progress is progress. Elaine was right. This is doing this automatically. I think there must be some timer. And then the last part, can we go back one slide? I hope I can do that. There we go. And the last part is we've gotten so good at sequencing. You heard about how cheap it's gotten, how in-depth it's gotten, the multi-omics. But what have we done in the last 10 years? And I've sat in these tumor boards. We take a tumor out, pick your favorite tumor, we sequence it, do all this fantastic stuff, and then we give them some therapy that probably is not relevant to that molecular change, and then the cancer comes back. And I'll talk a little bit about this problem. These are the things that ultimately result in the death of patients. We don't have very specific therapies for this, for these metastases, or if you're in medulloblastoma, the leptomeningeal space. And when cancers come back, we don't often know what that cancer actually looks like in detail. And these are very rarely studied. So, as a step back, this is kind of how I think of cancer. And again, these are not my concepts. These are decades-old concepts. Okay, but I think when I started my lab 15 years ago, I was like, well, if we don't address them, we're not going to get far. So pick your favorite area in the body, in the brain. Let's say in the cerebellum for medulloblastoma, maybe in the brainstem for DIPG, and there's some cells. How does cancer start? Usually what happens in one or a few cells is some change, whether it's a mutation or some epigenetic change, but basically that cell doesn't differentiate or stop dividing. That clone of cells takes over that field. You get additional changes. Immune cells come in, blood vessels grow, and ultimately you get a mess. This is what we are sequencing. They're not all homogeneous. There's cancer cells that are gray, there's some that are yellow, there's some that leave that main area, and we make an assumption, and we've made an assumption, and sometimes we still do, that they're all the same, or at least the way we use drugs to treat them is we're making the assumption that they're all the same. And we're learning, and thankfully we are, that, and hopefully we can implement that into clinical practice, is how do we appreciate the fact that they are different? So what we did, again, I'm going to go back and there's a few points there that I'll highlight, which are, we just took a whole bunch of cells in bulk and just started sequencing. And what we learned, and again, I'm going to talk all about pediatric brain tumors, but the only slides that you'll see that are adult brain tumors, is this one. So this is from 2011, and I highlight these years because we've known this information for now 13 years, 12 to 13 years. So if you take that sequencing of that glioblastoma, you can do gene expression, you can do mutations, deletions, and you can kind of categorize them. And I used this term earlier, like, are you a lumper or a splitter? And it's very easy to be a splitter because you can find differences, right? So you could say, hey, there's this group of glioblastomas that look like this, that look like this, that look like this, and they have maybe features. This group might have PDGFRA signaling. The red means it's high. This group might have EGFR signaling. This group might have NF1 loss. So you could say, hey, maybe this is what we're going to do. We'll find things that look like this, and we'll go after that drug, and it should work, right? Unfortunately, that's not actually what happens. So one of my closest collaborators, Matthias Nuderl, who at NYU, he actually was the first in the United States to get CLIA-certified methylation profiling. So when he was a fellow back at MGH, he did this experiment in 2011. He took that data, and he took a single patient. He said, look, if I took this part of the tumor, or this part of the tumor, and this part of the tumor, and this part that's moved along, and I said, hey, are any of these changes? And this is only the few genes that they made, but not the 20,000 coding genes that we have, just the 2 or 3. EGFR, PDGF, these are the colors. Some cells in this area have PDGF, some have EGF, and there's actually some cells that have both. So what do we do as clinical trials? We often pick, again, rightfully in a controlled way, a very reductionist approach. Well, we want to do it very controlled. So we'll pick one drug, and then we test that drug, hope it works. If it doesn't, we say the drug's not good, or it didn't work. Why is that? So I keep asking why, and I'll tell you some answers, I hope. So the first point I'm pointing is that all tumor cells aren't equal. You know, I'm not a pathologist, but if any of you have ever looked at a slide of a tumor under a dish, you don't have to be one. You can see they don't all look the same. It's kind of pretty obvious, but we want to think that, there's a simplistic way. It's a complex disease. I put this intentionally. These slides are 15 years old. Okay? So what do? We take now all of that sequencing. So sorry, guys. We do all of that sequencing, and then we give them radiation or chemotherapy. Something comes back, and sometimes we get some relief, a few years maybe, sometimes a little longer, but something's back. And many times we don't biopsy. And in fact, many times we still don't. We have no idea if it's the yellow cells that came back, the gray ones, maybe the metastatic ones that are just a little further away from that main site. And actually, what probably is the reality is, around this time in 2016 in medulloblastoma, Michael Taylor's group in Toronto took primary tumors that were resected, and in the same patient took tumors that, when they recurred, took them out and compared them. Okay? And what the point of this slide with the data shows is that when you look at the single patient at the beginning and at the end, how many changes, and this is just the coding changes, the 20,000 genes or so, about 10% are even retained. 90% are completely gone, completely different. And there's no similarity between the patients. So it's not like you could say, if you recurred, you all look the same. So this is the kind of data that has been around for 6, 7 years that say we should be biopsying. And I sit in some of the biggest cancer centers, and there's a disconnect between the data that's coming out so fast and what the clinicians and the hope of all of parents and families of what we can do, because just to be able to do something is hope, and we hope it works. But if we don't step back and realize that there are these changes, we're going to really steer the field in a way that is going to take longer. So we need to biopsy. And it's nice to see that consortia like PNOC and others are starting to put that phase 0 trials when you're doing clinical trials on therapy. Let's get a biopsy. Or if we get relapse, let's get a biopsy and at least use information. I usually use the analogy, if you don't, you're like an archer with a blindfold on and trying to aim at a target. I mean, chances are you must be really good if you hit that target. And none of us, I don't think, are that good. This applies to glioma. So this was 2016. This is a UCSF group. GBM, when we give radiation temozolomide, the tumors are different at the end at relapse. This is the CHOP group, neuroblastoma. It's different. probably almost all recurrent tumors. Unfortunately, in the brain, we don't have the luxury of always being able to biopsy, but if we can, I think it's something that we should be always thinking of as a field for that information. And it's not even as simple as just when that tumor returns, it's all going to look exactly homogeneous. What usually happens is that it's a mix, and you just have this mash again, and then what drug do you pick? And so I've seen tumor boards where things have, you've seen Foundation Medicine or whatever, again, not to sequence, and we pick one alteration. And I've sat in tumor boards for about 10 years now and asked the question, what is a term called variant allelic frequency? So what that means is, what percentage of the cells in that biopsy, either upfront or relapse, have the alteration? And if the answer is something very low, 5% or 10%, even if you had a beautiful drug, you could get it where you could get to, it should only kill 10%. But we try it anyway, which is fine. But this is a problem of the field, is how we approach this. So I've asked people in the field, I won't name names, should we as a field pick an arbitrary minimum? Just because we have a lot of drugs, a lot of money, 30%. I don't know what the answer is, but we have to come together and figure that out so that we can actually do this together and not in silos. And often, even as sophisticated or unsophisticated as that sounds, if we didn't biopsy, we ended up making choices based on the upfront tumor when the tumor relapsed. 90% isn't retained. You're aiming blind. So what we're usually doing is, again, many of you who've either gone through this personally with your own children or know of family members, we keep chasing the tumors. And the argument I'd like to make is, if we're going to not change the upfront therapy, there's a point where when tumors, they're very little, minimal residual disease, that's going to be the point where we want to hit them. But we have to be bold. If the molecular information allows us to do that, those are trials we should be thinking about. Yes, there's risk, you could be, but I think the idea is we don't want to go through this chasing, because as you keep chasing the tumor, it gets worse and worse and worse. So how do you get around that heterogeneity? And we need combinations. Obvious. Right? If every cell is not the same, you need at least 2, maybe 3, maybe 4. But here's the problem. The blood-brain barrier, which is a barrier for that purpose, is that it keeps things, good things, bad things out of the brain and keeps the things that the brain needs in the brain. But the problem is, if you want to get drugs there, you have to use pretty high doses. And the body can, unfortunately, in a developing child, we are limited by what that dose can be. And then if you think about adding 2 together, you can think about the additive. And that's why these trials are really hard to do. It's not as simple as let me just pick the 2 and combine them. I'll give you an example. Immunotherapies, the rage. Melanoma, where you give an immunotherapy, has had some success. But when you put 2 immunotherapies together, the New England Journal paper, 50%, half the patients can't complete the therapy. Those are adults. Imagine if this is a child. So I want to press that these are things that we have to think about. You heard yesterday from Dr. Martis, pediatric tumors, cancers, and brain tumors of all kinds, they don't have a lot of mutations. So you can't use these drugs that are developed in the adult setting for kinases that might only be 5% of the tumor or not even existent. So there's a lot of undruggable parts of the proteome, and how do you get at that? And I hope we'll have some answers here. And the biggest is the blood-brain barrier. And I think this is the angle that we decided 8 years ago, but 15 years ago, knowing that this was going to be the hurdle. So what is it? So most blood vessels have some type of permissive way to get things in and out. But the blood-brain barrier is a little different. It has these tight junctions to keep things in and prevent things from getting in. And, we put out a story, I'm pretty sure that's the reason I got invited to give this talk, that showed a way that we think we can carry drugs across the blood-brain barrier in a more efficient way. And it made a lot of press. I'm in Washington, so I thought I'd thank the NIH director. That once a week they put out you don't typically see peds brain tumors on the NIH director's website. But they thought that there was something here. And if you ask me, I could never publish another paper again. I'd be happy, whether with what we're doing today or at least the approaches that I'm hoping that others will use to get the field. It's a success, but not that I tout our horn, because there is some basis for this. The reason I wanted to talk about that was, everyone thinks, oh, drugs past the blood barrier, but it's really the underlying complexity. So 30 years, we've heard about nanoparticles. Many of you maybe have. And the idea is that there's small, tiny particles that can carry drugs, and they can sneak, and the idea was they can sneak in between gaps of blood vessel cells and sneak into the tumor. And there was a theory that's called the enhanced permeability and retention effect. And again, it's not important, but the idea was all based on this theory. About 3 or 4 years ago, a group out of Toronto kind of turned that theory on its head, and we were working on the same thing, but they didn't have a molecular mechanism. But what they really showed is they don't go through these gaps. They go through the endothelial cell, transcytosis. And I think that's what we showed in the mechanism of the paper, which I think hopefully with new medicines we think, and again, this is really relevant to DMG, pretty much all DIPG, they have an intact blood-brain barrier. And I'll tell you why I think that's important, because you've heard of this barrier, and I'll give you examples. About 2/3 of medulloblastoma, these are the two most prevalent pediatric brain tumors, have relatively intact blood-brain barriers. The ones that don't, they're still tight. They're just not as tight. So we got to get around it. This is really important, relative blood-brain barrier permeability. So you'll hear of drugs that are blood-brain barrier penetrant. When our paper came out in the last couple of months, 4 companies have reached out to me with drugs that are blood-brain barrier penetrant, asking us to consider using our system with their drug. I'm like, if your drug is blood-brain penetrant, why do you need our system? Right? So I use the term relevant or relative because I had unfortunately a family who had a relapsed tumor, and they were looking all around the country the last couple of weeks and asked about a drug. And I did some research, and it was a phase 1 trial that was published just 2 years ago. So this is not like 20 or 30 years ago. They measured how much of the drug gets into the CSF versus the brain. The ratio was 0.25. That means 2.5% of the drug, when you give it, gets into the spinal fluid. 97.5% is still in the serum. That's a lot of drug. That's toxicity. That was still enough to do a phase 1 clinical trial. Of course, the clinical trial didn't do anything. So we have to, as a community, and again, I urge it in a cooperative way, for the trialists, that we have to be a little more judicious, because we can't just put everything in and hope, because we're not getting very far, all right? So what if you could deliver an anti-cancer drug only to where the tumors are, right? What could it do? You might be able to make the drug better, maybe because more drug is delivered to that site. If the drug is delivered to that site, basically less is delivered elsewhere. That's where the toxicity comes from. If you can actually use less drug and at least keep the same efficacy, or ideally better, you can start thinking about 2 drugs together, because if you're using 2 drugs that are lesser doses, maybe that additive toxicity becomes less of a problem. So how do you get over that heterogeneity problem? And at the same time, the blood-brain barrier does good things. It keeps other bad things out and keeps things in. So you want to keep that neurovascular unit, the blood barrier, intact, which is why this mechanism of getting through transcytosis through the endothelium without blowing holes or things like that, I think is really what I am hoping this technology will allow us to continue to advance. Does it sound like science fiction? I guess I wouldn't be here if we couldn't do something related to this. And it's not like we came at, with this idea like out of the blue, like, it was an epiphany. The immune system does this whenever it's needed nearly every day, okay? So this is a 30-year-old hypothesis from the 1990s. And it's probably the way that if you had injury, infection, or inflammation anywhere in the body, how does the immune system know where to go? It just doesn't send white blood cells everywhere and just hopes it kills everything and then you'll be fine. It has a way to home in. And that mechanism is actually a receptor-based. There's a ligand on white blood cells. The names aren't really irrelevant, but the receptor is the blood vessels at those sites upregulate a receptor known as P-selectin. And it only upregulates this at that site. And the idea is, could we find a way to leverage that homing to carry not a white blood cell, but a drug, a cargo, all these other things? And the drug and carrier is called fucoidin. So I thought that made sense. Use something that's what's a biomimetic, something that the body uses anyway, and that's nothing artificial. The other interesting thing when we started this, again, I'm trying to think, how to, if you had a child with a relapse tumor, whatever type of tumor that is, and you had to have them choose an option, this trial versus what's been going on the last few years where reirradiation is a strategy. Or even upfront, if we were bold enough to give drugs upfront as upfront therapies, if radiation's a part, why do families and doctors who prescribe have to choose? So my idea was, this paper came out, again, not our work, is that if you took brain tumors in a mouse, in a rat, and you radiated the whole mouse brain, only the tumor endothelium, the brain tumor endothelium, upregulates P-selectin, but the normal doesn't. And we replicated this in our own paper, and I'll show you some data in DIPG as well. But we thought that could be another easier transition to a clinical trial, rather than here's a terrific tissue culture dish, there's no barrier, all these kind of problems that I'm trying to lay out for you. And then use our drug delivery homing mechanism because the radiation's already a part of therapy. I very intentionally put this dose because I know that in embryonal tumors like medulloblastoma, which is a quite radiosensitive tumor, we were able to work down our doses to 0.25 gray as a single fraction. Most children get close to 2 gray. And again, obviously, if you've gotten a very full dose of radiation as a child, you're limited by how much you can give. So I'm hoping that the clinical trialists will work together because we don't have very structured reirradiation protocols. We do stuff, but we haven't really tested what those are. And so these are opportunities in my mind that we can maybe spare side effects. And it's not just the drug side effects. Radiation is not great. There are a lot of pediatric brain tumors that when you're less than age 5, you don't get radiated. We do know that radiation works. We just don't have the neurocognitive sequela. We don't want that. In fact, there are papers with ATRT, that 18 gray, and based out of Paris, I believe, a couple of years ago, but it's that. So if this principle is right, and we can show that proof of principle in, let's say, DIPG or medullo at relapse, then the idea is at these low doses, I think those ATRTs and similar neuroembryonal, I think, is that we can maybe get away with giving lower doses of radiation that I think radiation oncologists might feel comfortable with, but then also give the drug. These are high risk, these young infant tumors. So I think this is like kind of thinking a little broadly about all the applications I'm hoping. So what is fucoidin? That slide came up. So to translate something, you can imagine if you took some synthetic polymer and said, I'm going to give it to a kid, can we do that? The FDA probably is going to make you go through a lot of hoops. Parents are going to go, well, that sounds kind of weird. That's found in plastic or whatever. So fucoidin is an interesting thing. It's actually a sugar, so it's organic. It's found extracted from the brown algae in the Sea of Japan. A company in Australia actually has been marketing it. You can actually buy it in a GNC store. In fact, the FDA has looked at it through their generally regarded as safe category. I'm not advocating because by itself I don't think it does anything, but people market it as such. So we think, and then up to at least 6 months through the GI tract, it's no toxicity against a sugar. And at the same time, people have used this for imaging studies. They've put imaging adducts to fucoidin injected intravenously into patients, again, shorter term. So we have data that this should be safer. The other important thing is, if any of you are involved with the industry, like how, it takes a long time to make a drug. You figure out a drug or a target, then you have to either pick your best drug that's out there, you have to make, this is really a long process. So my collaborator, Dan Heller, who is the chemical biologist that we started this company with, he developed one of the very first nano AI platforms, nanoinformatics platforms. So it's actually a way that we can, it was published in 2018. You can, just looking at the structure of a drug, you can predict whether it's going to be able to be formulated with this And so you don't have to go through this trial and error and however much time. You can kind of just do everything kind of. So I was always never kind of poo-poo about AI because I always say it's only as good as what you put in. But I think if you put in good stuff and good data, I think there's meaningful stuff that can come out. This is what fucoidan looks like. So we made these nanoparticles with a drug that's used in, I'm going to start with medulloblastoma, known as vismodegib, but they're also relatively, this is just, again, the importance of the technology of what we use, but they're small. They're about 80 to 100 nanometers. They're uniform in size, because you don't want, if they're too small, things like the spleen, the kidney will filter them out. If they're too large, greater than 200 nanometers, then things like the spleen will sequester them. So there's like a sweet spot. So it ends up that we can predict with that algorithm that they'll make these decent-sized stable nanoparticles. The other thing that's in the formulation is, again, mostly a sugar, the drug, and a very small near-infrared dye. And it's structurally similar to something that's been in patients for about 50 years called indocyanine green. It's used in angiographic studies. We use in the lab, we've done it with both. This is just an example of a cheaper version because the lab doesn't have that much money. But what we can do, at least in a mouse, and these are mouse brains, and I'll tell you, you heard a little bit comment about mouse models. I agree with Dr. Martis, they suck, unless you have a good model. And I'll tell you why the model that we use, because to prove this concept, there's a tight blood-brain barrier. So what this near-infrared dye allows us to do is we can inject this into the body of a mouse. We can either not irradiate the whole mouse or irradiate the whole mouse. So everything is irradiated, again, not like a patient where you do the craniospinal, but at least the point is that the forebrain is irradiated too. If you give this drug without radiation, the blood vessels and the tumor actually have some basal level or low level of p-selectin. So you can kind of see that in the area where there's no tumor, everything stays in the blood vessels. It doesn't leave outside the blood-brain barrier. You can start seeing some hint of it. And this is actually in our paper where it's efficacious, but mildly. If you give a small dose of radiation and a couple of hours later give the drug, it ends up all the drug goes to the tumor. The whole tumor is here in the cerebellum. Nothing goes up here and to the rest of the body, or very minimal. You can do this as a control. I think as a scientist, you should have controls. And so you can make another sugar that takes the same drug, same size particles, but that doesn't target p-selectin. And it doesn't, I'm sorry for the granularity in the picture here, but it doesn't target. So I think this is, we've proven this in different tumor models that are not brain tumors, different drugs, 2 different labs in 2 different continents. There's at least 6 papers published on this. So I think that, it's not just a one-hit wonder here. I think there's something behind this. And the immune system does this every day with this mechanism. So the comment about bad mouse models. So for about 8 to 10 years of my lab, I was kind of under the radar because I did think the mouse models sucked. And in medulloblastoma, yeah, they're models, all models to have some things. But it ends up that we made a model that was very similar of a sonic hedgehog-driven medulloblastoma that was like humans. So instead of starting with millions of cells at the beginning, we started with just a few cells. We made the alteration not with vastly overexpressed genes or knocking out 5 genes at the same time at the beginning. We did one that is found in 30% of human children with medulloblastoma. We made that mutation. And when we did that, a lot of things kind of coolly happened. It was a big gamble, but I took it because I thought it was worth it if we're going to try to figure out ways to get drugs to kids. And some of the things that it did was it created a tight, intact blood-brain barrier. So it ends up, that's what sonic hedgehog medulloblastoma patients do. This is Richard Gilbertson's work. This is not, others have proven this, but we kind of dismiss it sometimes. And the way we did this, and this is called a survival curve, and we used the mouse models that were really, we thought, relevant. 94% of my mouse model has leptomeningeal metastases. Almost every kid with medulloblastoma has, even if you don't detect it, has at least micrometastases. So we're treating mice that have that. We also had the liberty in this model of, you might see this in papers as you evaluate or hear, oh, this sounds great, but what you end up doing is treating sometimes mouse models where the tumor's not really that big, it's very early, it's very small. And you kind of see, does the drug delay treatment or delay growth or something? I kind of thought that is never how we're going to do this in a kid. These are advanced tumors. They're very aggressive. So if we're going to try to get something that gets into the brain and effective, let's make this hurdle as high as possible preclinically. So we treated when they were basically at death's doorstep. And if you do control or untreated, they die in 3 to 5 days. If you give 8 doses of radiation, it is a radiosensitive tumor, so they survive about something like, 22 days or so, 21 days, the green line. If you give our nanoparticle version of the drug, that's the blue line, 8 doses, it does something without radiation. I told you, but it was marginal. But if you give radiation 8 doses, the treatment stops here. These tumors are massive. You saw the picture. It takes up the whole cerebellum. There's not residual disease here. And if you combine it, you get this yellow line. And we stopped treatment. We're just working on ways to go longer. If you now take that same drug without the nanoparticle targeting at the same dose and give radiation, it's the same as radiation. So it's not radiation sneaking this drug in or anything. This is an active transport pathway. Here's the important thing. So the other thing that we do is, again, treat it in advanced stages. We want to use drug payloads that we have a lot of data, either phase 1 safety profiles that we know in kids, or at least in animal models so it ends up Genentech. This is a drug that's FDA approved for basal cell carcinoma. In mouse models of medulla, you need to use 100 mg per kilo over several days. Published Science paper, 2009. We're doing this with 1/10 the dose. Okay? Again, I think that's important for translation to kids and minimizing toxicity. So sorry. And we think that if we can do this with known drugs and in known indications then we think this opens up novel drugs, and I'll talk a little bit about that. Make sure I'm doing okay on time. Okay, I better hurry up. 2008, the same drug was given to baby mice. It caused premature growth plate fusion. We showed that this nanoparticle doesn't do that. We gave it to baby mice, and we showed that it's the controls here. Here's the free drug. They're smaller. They have smaller long bones. They lose weight. This is a CT scan of the bone, and there's a lot less bone here compared to the drug. Again, not in a disparaging way, but around 2012, we knew this data. The clinical trial still happened. I asked one of the leaders of that trial, don't you know, aren't you worried? And it's not an answer I like, and it's a true statement, which is, we won't know till we try. But I'm like, then what's the point of doing all the work before? So 2017, every kid who didn't have now the FDA does not like this drug. It's a great drug, but it works against the tumor. But everyone is now a stunted dwarf. And this goes on and on. Pick your favorite drug. So I would like to suggest in what we do, and I hope others, because if we're going to put drugs into kids, this is the cheapest experiment you can do. In fact, companies have asked me about their adult drug, and it's like, we'd like a pediatric indication. I was like, put it into baby mice, and you'll at least have some baseline what toxicity is, because these are all developmental pathways that if you're blocking growing cells, you're going to block developmental pathways. And if you can show that, at least you have data, but otherwise you got to be on the lookout for it. Just a couple of examples, other classes of drugs. So I think pediatric brain tumors and pediatric cancers are not necessarily considered what we think of as genetic cancers. Adult cancers are. They're driven by lots of genetic mutations. These are developmental cancers. They might have some mutations in them, but they also have a lot of epigenetic. Basically what happens is cells can't differentiate. They can't stop growing. And those are epigenetically typically. Sometimes there's an oncogenic pathway that can regulate that, but if you don't have a genomic target, like a kinase, what are you going to use? So EZH2 inhibitors, this is a master controller of neuronal cell differentiation in normal development. A cell proliferates, it has a lot of EZH2. When it differentiates, it's shut off. If you look at a lot of cancers, not just brain tumors, EZH2 is highly expressed because it's that inability to differentiate. So we thought if we're going to make this hurdle as high as possible, there's at least 3 companies that have EZH2 inhibitors. It's well known they do not cross the blood-brain barrier. Well known. In fact, there's no active programs out there for brain disorders with EZH2. So if we can do this with something like that, that's another hurdle if we can show that proof of principle. So we made nanoparticles. We showed that there's a biomarker of response. And similarly, at death's doorstep, we treated these mice, again, using doses that are 1/8 the dose. And importantly, when people have tested this in DIPG cells, in medulloblastoma cells, they've either tested doses in a tissue culture disc, there is no barrier, or they've tested in the flank, a brain tumor in the flank of a mouse, there is no barrier. They've sometimes stuck a CED catheter that was published out of Lurie. You directly get it in. It works if you can get the drug there. And the last one is a fourth group, again, all groups that are not my group, but if you take a drug called elacrodar, which is so toxic in patients, but you can break open the blood-brain barrier and then give it. It works. So we can do this. And we think this has, as a single drug, implications for a lot of developmental tumors where epigenetic ability to differentiate is there. Okay, let me hurry a little bit. MEK inhibitors. So this is not outside the brain. So trametinib, this is actually binimetinib. If you end up looking at, this is again not brain tumor models, but I want to show you that what we can do with these drugs and make them better therapeutic index. We can basically use about 1/10 the dose of the MEK inhibitor. We can show that the pharmacodynamics of the drug are changed. We can sustain the activity of the drug longer compared to the free drug. That's the red versus the blue. When you use the same dose of the drug, it does nothing to the tumors. But if you use the nanoparticle-directed delivery, those low doses kill cells. And those of you who've ever had a patient or know of patients who've gotten a MEK inhibitor, they all get a rash, anywhere from 40 to 70%, and sometimes it's debilitating. Mice don't get rashes, but we can detect whether we're affecting the skin. This is the skin and looking at the downstream target. And so when you give, you have to give 300 mg per kg, 10 times more of the free drug dose to actually affect the tumor, but you wipe out the target in the skin. This is why we get a rash in those kids. That same effective dose doesn't. PI3 kinase inhibitors. Again, we can keep going on and on. There's 300 drugs here that I'm not going to go over every one. This is head and neck cancer, another one that gets radiation. This is a drug that you can sustain the activity of the inhibition longer, so that the dosing is less. By using less dose, again, 1/7, the tumors don't grow higher. And importantly, every PI3 kinase inhibitor that's used, you get this problem. This is how we know it works. It causes your blood sugar to go through the roof. It's a problem, because if you believe that sugars like glucose can feed a tumor, I'm not sure that necessarily that's a good thing. But also what patients get is you have to give insulin or metformin. You're kind of just making the polypharmacy even more complex. And how are you going to get now a fourth drug that goes after the tumor just to treat the symptoms of the first drug? This is measuring blood glucose. The free drug, glucose goes up. There's a response of insulin. The effective doses, it doesn't. Okay? So what can we do with this? We need combinations. A lot of it is undruggable. So I like AI now. I've become a fan. So like I told you, we can take small molecule drugs. There's a lot of them already there. If they're free and generic, I would love to just do that. If they're licensed, we have to license from companies, we'll do that. But we can just tell you for straight up front. And collaborators have reached out to me. Hey, what about this drug? And we've done this with them. PPM1D inhibitors, for example, which are in about 10% of DIPG. We can tell you we can make it better, and then we're testing that. But at least 300 known FDA drugs can do this. Yossi Shimei, who was the first author on the original P-Select, and he has his own lab in Israel, just did this beautiful paper that came out a month ago. So how do you get combinations? So I'm going to give you the example of dabrafenib and trametinib, which is low-grade glioma, right? It's now the FDA-approved therapy, a BRAF inhibitor and a MEK inhibitor. 20% of those kids get a grade 3/4 neutropenia. About 3 to 5% get a grade 3/4 severe liver problems. It's because dabrafenib has a half-life, which means when you give it, how long does half of the drug stay in the body? Of 4 hours. Trametinib has a half-life of 96 hours. If you want to just mix two drugs together and say, I'm going to combine them, you have to give them independently. And if they don't have the same pharmacokinetics, you're limited by what you can do. And often the only way you're going to do it is give such high doses that you're going to either get to a limit where the kid can't take it, the patient can't take it, or you just won't get efficacy. So what this is a AI platform using our difucoidin nanoparticles, that technology, where we can now, from the molecular structure of two drugs, actually predict which two can come together in the same nanoparticle and make a stable nanoparticle. The idea is, if you're going to give two drugs, you want that target tumor cell to see both at the same time. Sounds science fiction, but doable. In the mouse, we've done this. We have a second P-selectin targeting technology with dabrafenib and trametinib, where with BRAF V600E mutant tumors, we can use 1/30th the doses of those two drugs. We'd like to take that into low-grade glioma. Okay, I'm going to finish up here. The undruggable. 85% is undruggable. They don't have kinases. So there's these degraders. Dr. Martis talked about this yesterday. They're PROTACs. You can go after proteins that aren't classically blocked by chemical inhibitors. They're large proteins. They don't cross. Ask anybody. In fact, one of the leaders, Jian Zhen, people try to, hey, can we squeeze it in? It's like, you can't. You just can't. We can do it. So we put fucoidin, to our surprise. We made nanoparticles. This is BRD4. Those of you who have funded funds in the last 15 years, it was all the rage. BRD4, they're toxic. That's why they haven't been approved in 15 years. But they're really, I think, good drugs, meaning that they're efficacious, but we just can't give it. So we did a degrader that's BRD234. We made nanoparticles out of it. This is a medulloblastoma model. We can now target it to the medulloblastoma. The tumor is actually right there. Here's a tumor that it's the whole cerebellum, but we knocked out P-selectin, so it doesn't really target. These are controls. And again, in an intact blood-brain barrier, on the other side, we can degrade that protein. We've done this with EZH2 degraders, and now we're working on MEK degraders as well. This is a xenograft model of DIPG, human. We took an EZH2 inhibitor and asked, can we actually target this to this disease? Xenograft models are okay. I think they have leaky blood-brain barrier, so you might argue, well, yeah, sure, you have a wide open door, you can get it there. So I was lucky enough to recruit Oren Becker, who developed the very first genetic mouse models of DIPG almost 12 years ago, to join me at Mount Sinai, because I knew that he had a really good model. In fact, they have intact blood-brain barriers. The reason I know it's, I think, intact and relevant to humans is because other examples you can think about, like the ONC201 trial. Why is DIPG excluded, but other DMG not, unless that's changed? Either DMG is different than DIPG, or there's something about the delivery in that brainstem that's different than a higher up. I've seen kind of preliminary data with things like avapritinib, where efficacy in DMG, but not necessarily in the brainstem part. So there's a barrier, and a significant amount of DMG is DIPG. So we took this genetically engineered mouse model, which has a tight barrier. We irradiated it. The purple is the tumor cells, the green is the blood vessels, and we can get P-selectin to come up. Some collaborators from Johns Hopkins, we took human DIPG cells. We can see in real human samples non-irradiated, because we typically don't get biopsies after irradiation. It's there. So I took his genetically engineered mouse model, tight blood-brain barrier, took a PROTAC that is a large molecule that does not get in, and guess what? It goes to where we think it's going to go. So this is all preliminary, but we think that we're on a track to actually getting those undruggable drugs, those tight hurdles, and make it harder. So in the last two slides, I will finish. I know Lisa's going to hook me off of here somewhere. How are you going to go after metastasis? So as I mentioned, our preclinical medulloblastoma model has leptomeningeal metastases in 92% of the mice, 92%. They have P-selectin when those mets are large. We're working on ways to do intrathecal delivery, because it's going to be hard to get the vascular system to there, but if we can have the target, that's a way to get there. As I mentioned, DIPG and other infiltrative gliomas are infiltrative. So how are you going to get there? Surgeons do a great job. They take out everything that you study at the single cell level. They take out almost all of it. What's left is the stuff at the margins. What's left at the margins has a tight blood-brain barrier. I'll just show you a little bit of data. This is a high-grade glioma model. The tumor is kind of where the blue ends. So the edges or margins are here. In fact, there's even some tumor cells away, and I hope it projects well, but we can actually, at least in the absence of radiation, see P-selectin at those sites. Now, this is important because if you follow the field, there's two ways glioma cells move. One is through white matter tracts, and the other is through blood vessels. And so our working hypothesis is that if they actually touch blood vessels, they inflame them or activate them. So can we use that to go after metastatic disease? And then the last part, again, I promise I will finish, this recurrence relapse problem. Again, all with the same approach. Again, I don't know what the right drug is. It's going to be different for every tumor. It's going to be different for every combination. But Richard Gilbertson and Eric Holland and Fred Hutch showed in both high-grade glioma and in medulloblastoma that if you irradiate these tumors, the cells that survive, again, those minimal residual disease, those cells remaining, they tend to live right next to blood vessels. It's called a perivascular niche. Wow, wouldn't it be cool if you had a drug delivery system that goes through the vasculature and can see those are the first cells that you see? So our working model, our model, in Medullo at least so far, and in GBM from Dolores Amberzumian, says that this model is right. And so we're trying to study what drugs to go after in that. So the idea is you give radiation, and then maybe the drug you would pick is the one that is active in those few cells to go after those last few cells. And again, you're not changing landscapes of trials. It's no different than somebody trying something with a blindfolded recurrence versus that. So it's an opportunity. Stay tuned. So take-home points. If we can get drugs to where they need to go and not where they don't need to go, that could be a really big advantage. If we can do this in a way that is already a part of a standard of therapy, like radiation, either upfront or at reirradiation, I think that's an opportunity to get things into the clinic easier. Again, if you can increase that therapeutic index of something by 5 or 10-fold, it opens up the opportunity of using 2 or maybe more drugs together without those additive toxicities. Those undruggable targets, we think we have an opportunity now to do that, and actually RNAs as well, but we didn't go over that. And finally, this platform allows us to put 2 drugs into the same delivery so that the cell sees both drugs at the same time. And that changes the whole properties of half-lives and everything, as you can imagine. So these are my final take-home. So this only worked because it was collaboration and team. I was at a meeting by a chemical biologist who was working on this. I think about brain tumors every day. If those who know me, I can't stop talking. It's probably why I'm 5 or 10 minutes over. But I said, look, it'd be cool. We got to do, high risk, high reward. And I'm glad this worked out. Again, humbly I ask this, but we need to be a little more nimble. Clinical trials take years for drugs that we're not getting a lot out of that clinical trial. So it is nice to see that PNOC and others, I'm not singling them out, but if we know that a drug's not going to work, we got to change direction quicker. So that's what I mean by nimble. And we have to raise the bar of what we actually use. I mean, just to say something is blood-brain barrier penetrant, it's like 2%. I hope it works. But I think the reality is, it's probably going to be low. So we need to make those hurdles very high, and that's why we approached it in the lab, which is why I've been under the radar for 10 years. Because I think if it didn't work, it's fine, but I think those are the challenges we have to go after. More effective, less toxic BBB penetrant drug combinations are needed to handle these hurdles. And I love this quote because it's true. If we keep doing the same thing over and over again and expect something different, it is Einstein's definition of insanity. I love this meeting. I hope we never have it. That's the goal. This is my team. My main collaborator is Dan Heller at Mount Sinai. We have international partners, others who've decided, hey, you know what? We want to try our drugs in your system. I said yes. I never say no. If you reach me, you can realize I'm easy to get a hold of. And people who've also been very forward-thinking of the problems of heterogeneity and stuff, because I think if we don't address the hurdles, we're going to just keep doing the same thing, like sweeping them under the feet. A lot of foundations funded me. Some are here. Emerson Collective, which is related to one of your sponsors, Yosemite, Unravel, who took a really big risk and gave me really unrestricted money, but not, a good amount. That's a lot. Again, a lot of this funding, I'd say about 60% of it is not funded by NIH money. I just felt that was the important thing to do. Don't tell the government. I'm sure they're here. Thank you, and that's it.
The show the show will begin in 3 minutes. Thank you.
Good morning, everyone. We're so excited to have Dr. Willard, an associate professor and psychologist from St. Jude's Children's Hospital. She's here to talk to us today about emotional impact and some of the things that we don't always talk about and some of the topics that are more difficult and challenging, whether you're a parent, sibling, survivor. Some of the things that we see, but we don't always know how to talk about them. So her groundbreaking research is really helping us understand what the impact is and some interventions that may be able to help people achieve their ultimate goals.
All right, good morning, everyone. See if I can make my clicker work. Did I do that? There we go. Okay. Good morning. My name is Dr. Tori Willard. As Stacia said, I'm a psychologist at St. Jude Children's Research Hospital in Memphis, Tennessee. And my research over the last 10 or 15 years is really focused on social and emotional challenges in youth with pediatric brain tumors after diagnosis into survivorship. So I'm really excited to talk to you about some of that today. So our objectives today, we're going to define social functioning. What is it? How do we do it? We're going to review some of the literature on social and emotional functioning challenges in survivors of pediatric brain tumors, and then really spend a lot of our time discussing some of the practical strategies for coping with these challenges. Unfortunately, the literature for interventions, as I'll talk about, is kind of few and far between. So we're going to spend our time talking about just some of the practical strategies and things that we can do in our communities. So quick couple disclosures. I don't have fancy ones like a lot of the medical oncologists. No drug company tells me to do, funds my research or anything like that, but a couple of disclosures. So the content of this talk is really the sole responsibility of me and doesn't necessarily represent the views of St. Jude, though I do work for St. Jude. I am a psychologist, but this talk really should not be taken as a substitute for mental health services. So that's just something to keep in mind as we go through. And then, whenever I talk to families and we talk about challenging situations or challenging topics, I want to make a note on kind of personal boundaries. So if we have time for questions at the end or as you're thinking, just keep in mind kind of what your own boundaries are for how much you want to share and how personal you want to be. We're all friendly people here. No one's out to get anyone. But as we talk about challenging things, it's good to just keep that in mind. So social functioning, what is it? I think we all use the word a lot, but we don't often talk about what it is. The definition that I like best is one that's really simple. It's our ability to interact competently with other people across settings. It's simple, it's straightforward, but doing it is complicated. Interactions typically, when you're a kid, involve same-age peers, and really the interactions that you have with others throughout your life form the basis for interactions that you have for the rest of your life. And competence in these interactions, how we interact with other people, both when we're kids, when we're adults, are critical for both our present and our future well-being. So a term that's used a lot in the literature and in the media that also encompasses social functioning, but is maybe a little broader, is this idea of social emotional learning. This may have been something that you've seen just kind of in media articles or in schools or things like that. And the idea of social emotional learning is it's this idea that our ability to interact with others, to manage our emotions, and to be good humans is a skill that we have to learn. It's a skill that we have to be taught. It's a skill that we have to practice. And they are skills that take us across communities. So wherever we are, the social emotional skills that I'll talk about in a minute are used in our interactions. So there are 5 skills that kind of make up this idea of social emotional learning. The first is self-awareness, and this is really this idea that in order to interact with others, we need to understand ourselves. We have to understand our own emotions, our own behaviors and thoughts and values, and how those emotions, thoughts, and values influence our behavior. So we need to know, for example, that if we're sad or angry, we act in a certain way. We're more likely to act in that certain way so that we can move into self-management. And this is this idea of managing your thoughts, emotions, and behaviors effectively in different situations. For example, if we know that when we are sad, we want to curl into a fetal position and be a turtle, that works really well when you're at home. Doesn't work so well when you're at work or school. So these are different ideas of knowing our own emotions, knowing our own instincts, and knowing when and where we can act in those ways, and when maybe we need to change how we're doing things. Then there's social awareness, and this is when it kind of moves outside of ourselves, and it's this understanding the perspective and to understand the perspectives and to empathize with others, including those from diverse backgrounds. So it's understanding the different people that we interact with on a day-to-day basis and where they're coming from. And so just as we're managing our emotions, recognizing that they are managing theirs, that we don't know where they came from or where they're going, but in this interaction, we're going to have an understanding and empathize with where they're coming from and reduce our judgment as much as we can. And as part of this, these are relationship skills. These are the idea of to establish and maintain healthy and supportive relationships and to effectively navigate these settings. So these are the skills that we use to do this. We interact with people constantly, whether it's in a setting like this where we're sitting at a table with someone we don't know, or with me talking to a room full of people and I'm making sure that I want to talk to this side as much as I talk to this side, even though my screen is over here, I apologize. as well as some people online. These are skills that we use all the time and in different settings. So we want to make sure that they're ones that we're practicing all the time and not getting stagnant. And so finally comes decision making. So every day we make caring and responsible decisions and constructive choices about our personal behavior and our social interactions. So it's always interesting because a lot of these skills in some ways, for many of us, they come really naturally. We're just social people in general, but for a lot of people, they don't come naturally. Or for some people, they've had a diagnosis or treatment that makes these things come less naturally, and that's our survivors of pediatric brain tumors. So I want to talk a little bit about developmental considerations. We are to talk with kids or about kids, and kids go through many different stages and ages as they grow. And as we think about social functioning and as we think about emotional functioning and the skills that kids learn, they're very different depending on the age of the child or the age of the young adult. So we will have very different expectations for how a preschooler is going to act versus how a high schooler is going to act. We need to have very different expectations for that, and we need our kids to grow and to engage and learn these skills and get better at them as we go. A 4-year-old can throw a tantrum when they're angry. I can't. I mean, I could, but y'all would give me some weird looks. So we need to be thinking about the different developmental considerations and how old kids are and where they are kind of in their life as they're moving through. But we also need to think about the age at which our kids were diagnosed. So if we think about early childhood, our infants and preschoolers, we think about our school-age kids, early, late, elementary, middle school, we think about our adolescents and young adults. And it will make a difference where a child goes based on when they're diagnosed, based on how much time they had before their diagnosis. So an infant or a preschooler didn't have a lot of time as a typical kid to do a lot of development before their diagnosis, whereas a 16-year-old did. So if you think about kids going through treatment, your 4-year-old is going to be really dependent on mom or dad to help them as they're going through. A 16-year-old is going to be like, Mom and Dad, please go away. I need to talk to my friends. It's just different ways of thinking about things as we move forward, and then thinking about the trajectories as we move into survivorship. So I know you all know this, but whenever I give a talk, I always like to kind of center all of us on what we do know, even if we all know it, in terms of kind of where we are medically and what we know about kids with brain tumors. So I know you know this. I'm going to spend about 3 seconds here. So brain tumors are the most common solid tumor of childhood. They're the second most common cancer diagnosis after acute lymphoblastic leukemia. Brain tumors, unfortunately, come with a host of late effects as a result of their diagnosis and treatment. They're neurological, they're endocrine, they're neurocognitive, they're psychosocial. On the neurocognitive and psychosocial component, I am a psychologist, that's where I focus. There's been significant literature that has been done on the characterization of an intervention for neurocognitive late effects. You've heard about a lot of these, you know this literature. Understanding of social emotional outcomes has really lagged. We focused first on how kids did in school, with maybe not recognizing that a big part of school is how you interact with other people. But we're getting there. We're starting to catch up. But what we know from some long-term studies, data from the Childhood Cancer Survivor Study, data from the St. Jude Lifetime Cohort, is that our survivors of pediatric brain tumors are not achieving the developmental milestones of adulthood in the same way that our other kids are, in the same way that their siblings are, in the same way that kids with other cancers are. They're not employed at the same rates, they're not driving, they're not achieving normal educational milestones, they're not living independently, and they're not dating. And these milestones, these are social. These are social milestones. Yes, your neurocognitive concerns play a role in this, but these are social. It's how you interact with other people across settings, so using a lot of those social emotional skills we just talked about. When we back up to adolescence, we start to understand what some of these deficits are that lead to some of these delayed long-term milestones. So this is data from the Childhood Cancer Survivor Study. And what they did is they kind of gathered a lot of information together from parent report. So parents filled out questionnaires about how often they're a brain tumor survivor, how many friends they have, how much time they spend with friends, the quality of those interactions, some of their behaviors. And what they found is these kids kind of divided out into 3 categories. So about 50%, which is good news, we like 50%, that's half, are well-adjusted. They're kind of doing what you expect they should be doing as compared to a typically developing population. But our other 50% of kids broke down into kind of 2 categories. So the green bar that you can see, these kids, they were labeled it's about 30% of kids, and these kids we consider kind of our poor peer relationships kids. And so these are kids that they're well-behaved. When you get them with someone, they do a really nice job, but they just don't have the number of friends or are spending time with friends in the way that we would want them to and what is typical for their age. And then in your blue bar, which is about 15% of kids, these were kids who were struggling kind of across the board across these measures. That's why their line is so high, and that's about 15% of kids. So oftentimes when you're doing social functioning work with typically developing kids, we go into the classroom. We don't tend to do this as often for brain tumors because brain tumors, fortunately, is a pretty rare disease. And so if you need to go find a brain tumor kid in a classroom and you want 30 kids, you're going to go to 30 classrooms. So that's a lot of work, probably at 30 schools as well. So, but this study did. I have some colleagues who really focus on this quite a bit. And so what they do is they ask kids in a classroom to cast their classmates in a play. They have a list of different kind of characters in this play, and they have a list of their classmates, and they're asked to cast them in this play. And what we see in the red bars is that in this play, our kids with brain tumors are seen as less popular, less aggressive, more isolated, and more victimized than their counterparts, than their classmates. But what is really interesting is that when you ask a brain tumor survivor to cast themselves in this play, they're popular, they're not isolated, and they're not victimized. So there's this disconnect sometimes between what we see as we're interacting with these kids and what these kids see for themselves. And that's kind of that idea of that self-awareness piece potentially coming in. So for me, when I see data like this, I want to know why. Because until I know why, I want to know why they're isolated. I want to know why they don't see that they're isolated. And I want to know why they don't have friends. Because for me, until I can know that answer to why, I can't fix it. I can't do anything about it. So that's where this comes in. So this is how I think about social functioning in kids with brain tumors. And emotional functioning comes into this too. So this model, essentially there are 2, do I have this? Oh, I do, fancy. So there are 2 kind of skill-based factors here. So your neurocognitive factors, obviously attention, working memory, processing speed, all of the neurocognitive deficits that we know that come along with brain tumor, this is going to play a role. I'd have an inflated sense of self-importance if I said it didn't. It absolutely does. But there's also social cognitive factors. So these are some of the social skills that kids can be taught in order to do some of these things, and I'll talk about this in a bit more. And both of these 2 things together influence social experience. And social experience for me is this idea of interacting with other kids. What are you doing on a day-to-day basis? Who are you hanging out with? Being a kid. It's the social piece of being a kid. Affective experience is the emotional piece. So things like anxiety, depression, loneliness, isolation. It's things that are absolutely going to influence how you interact with others and be interacted with by, you know what I mean. And then certainly medical factors also play a role here. So this is things like that age at diagnosis, whether you were 4 or 15 when you were diagnosed, the type of tumor you had, whether you received radiation, things like that. So unfortunately, back that up. So I've got several studies right now that are trying to characterize factors across these different studies. Fortunately, this data is not yet published. COVID's really slowed us down, as it did for everyone. But I am going to give you kind of a high-level sense of what we're seeing with some of these data. So in terms of neurocognitive weaknesses, we're absolutely seeing deficits in these kids in attention, working memory, processing speed, and executive functioning. We expected this. This was really more kind of a check. And if you think about neurocognitive skills, if you think about a social interaction, they happen really quickly. It's a small change in the way that someone's face moves or the expression that they're saying. It's a quick joke. It's sarcasm. These are things that happen very quickly. And if you have trouble with working memory, so you have trouble holding things in mind, it's going to take you a minute. And in a social interaction, you don't have a minute. Same with processing speed. If it takes you a little bit longer to do something, you can't have that in a social interaction. I can't slow them down. I wish I could. But I can't give extended time in a social interaction. Same with attention. If you're just staring off over there, you've missed half of what happened because it's happening so quickly, even if you can bring it back. And certainly in some of the interventions that have been done with for neurocognitive concerns, we have seen improvements in social functioning when we do target neurocognitive concerns. Most specifically, there was a large study done many years ago now with Ritalin. So we did see improvements when kids with brain tumors and leukemia were put on stimulant medication. We did see improvements in social functioning to kind of manage some of that attention. So from a social cognitive perspective, and this one's different, there are 3 skills that we're looking at. We're looking at affect recognition, which is that idea of understanding a facial expression as it's happening. And I've done a lot of research in this area, and what we tend to see is that our brain tumor survivors, they struggle with this. They struggle to identify facial expressions. But they struggle the most to identify those expressions that are more negative, so sad or angry, disgust, fear, things like that. They get happy. They're pretty good at that, which is great. We want them to be good at happy, but they're not as good at the other ones. And they also struggle with those expressions that are more of what we call low intensity. And so those are the expressions, it's a slight smile. It's a slight reduction in the eyebrows or raise of the eyebrows to kind of indicate to someone, I don't really want to be here right now, but I'm going to be polite about it. It's that polite smile that we have all used. They're not picking that up, and that's going to be the piece that's really going to struggle in social interaction. Theory of mind or perspective taking is that idea of understanding that what I know, you don't necessarily know. And so a common kind of question or way that we assess this is we tell a story of a kid goes into the kitchen, sees a box of cookies on the table, gets excited, opens it, and inside the box of cookies is spaghetti. That's weird. So then you ask the kid, if your brother then came into the room and saw that there was this box of cookies, what do you think he'd see or think was in the box? And a kid who struggles with perspective taking would be like, oh, he knows it's spaghetti because I know it's spaghetti, so therefore he knows. There's struggles with that understanding that there may be differences in what different kids or different people see depending on those, on what they know, on their knowledge. And then finally, problem solving. Social functioning in any ways is one big problem. Every time we interact with someone, there's something we're trying to figure out. And especially there tends to be a lot of challenging social situations, especially during your school years. So we've done some work that suggests that when our brain tumor survivors are faced with a challenging social situation, they want to play with someone on the playground and they call their name and that person doesn't answer. And so we ask them what they would do. And for many of our kids, their most common choices is they'll either wait it out, they'll just kind of hang out there until someone pays attention to them, or they go ask an adult for help. And that works. Asking an adult for help kind of has its pros and cons. When you're 7 or 8, it's kind of okay. When you're 10, 11, 12, and you're the only kid always running to the adult to ask for help, that's not working so well anymore. And then finally, in terms of kind of general social functioning, that social experience piece, this is all from parent report measures that we're asking our parents to fill out. We're seeing that our kids are experiencing more peer rejection, fewer positive peer interactions. They struggle with social awareness, which really goes along with a lot of what we're seeing in some of the skill-based work. And they also struggle with social motivation. So social motivation is kind of this idea that I'm more comfortable on my couch and I'm not necessarily going to go out and find anyone to hang out with because I'm comfortable where I am. So that motivation to go and find other kids and to create social opportunities isn't there in the way that we would want it to be. So some other work we've done as part of one of this study is we ask kids a pretty simple question. These are school-age kids. Do you have a best friend? Most kids can answer this question very easily. Even your 3-year-olds can answer this question pretty easily. But what we found is that in our sample, 20% of our kids could not identify a best friend. They didn't have one. Some of them thought they did, and their parents were like, no, I don't know who that kid is. But 20% of our kids could not identify a best friend. And that one question was really interesting because what we see is those kids who could not identify a best friend self-reported lower scores on social competence and on self-worth. And so even though these kids struggle sometimes to identify where their place is in the social hierarchy, to understand how they're doing, they know that most kids are supposed to have a best friend and they don't, and that matters to them. The other interesting piece was we had parents fill out a questionnaire talking about what they do to support friendships. How do they help their kid with friendships? And those parents of kids who didn't have a best friend were doing less to support friendships than our parents of kids who did have a best friend. So I'm not blaming parents here. By no means do not think that's what I'm saying. But it's this idea that our kids with brain tumors are different. And so maybe you have other kids who are social. They're like, Mom, I want to be on the soccer team. Mom, I want to, like, Joey and I met today, and I want to go have a play date with him, and please call him, and I'm going to go out. There's 4 kids out there on the sidewalk, and I'm going to go hang out with them. Your brain tumor kid is not necessarily going to do that. It's that social motivation piece. So they may need a little more help in order to create those opportunities for them. So not, do you want to take soccer or do you want to take karate? It's like, you're going to do an activity. Do you want soccer or karate? That idea. So it's kind of making them do that and creating those opportunities for them. I'm not talking helicopter parenting. I'm not talking snowblower parenting. I'm not talking lawnmower parenting, all these different ways of parenting that are talked about all the time. But it's fine helping them find opportunities and creating those opportunities and dumping them in there, as well as teaching them these skills. So it's a friend of yours has a same-aged kid. Let's get them together and all go to the zoo together. That creates an opportunity. Because otherwise my fear is, and the risk is that these kids will stay on that couch. And as much as we would like them to, our friends don't tend to come to the couch until we invite them. They don't just show up there. So intervention on social functioning. I wish I had better news. It's not great. So there's several years ago now, 5, which is crazy to me, I did a literature review paper of the social skills interventions that have been done for survivors of brain tumors. There were 9 interventions published. There might be 10 now, maybe. It's been a while since I looked. None of them were good. None of them are ones that I would recommend to our families. Many of these were group-based, which we all know you don't want to come back to the hospital to do this. The hospital's far away. I work at St. Jude. I can't bring you back from California to Tennessee to do a social skills intervention in person and group-based. That's not going to work. If we are on treatment, that's a different story. We'll talk about that. Most of the interventions were just kind of created for that study. There wasn't a lot of evidence behind them. They weren't looking at the literature because this literature is really still developing. Until we know why our kids are struggling and what skills the issues are, we don't know what to tackle. And part of the problem has been is that the way that we assess and measure social functioning is kind of problematic. It's not great because so much of what's been done in the typically developing literature has been in our schools. And so we're not in the schools, that's not how we want to do this, and so we've been looking for other measures, and that's kind of a secondary objective of everything that I talk about and everything that I do, and we're finding some better measures, so we're getting there. We also have to consider developmental considerations. Many of these interventions were designed and included kids who were 8 to 16. I don't know about you, but an 8-year-old and a 16-year-old have really different social needs, and I can't teach them in the same way. The interactions and the examples and the role plays and the things that we're going to do in order to help them build skills are going to be very different, and we need to think about it that way. And then, as I said, these were all group-based. It's not going to work in survivorship. It may work when kids are on treatment. That's something I want to try, is to do some group-based social skills interventions, take a more preventative approach for our kids and get us thinking about this very early on for our kids. But it's not going to work in survivorship. So we really need to be thinking about computerized measures. We need to be thinking about telehealth. We need to be thinking about different options. All right, so unfortunately, I've got one quick slide on kind of the specific emotional challenges. There just hasn't been a lot of literature in this area. But we do know that broadly 15 to 30% of survivors of childhood cancer, so broad childhood cancer, do report some psychological concerns, anxiety, depression, things like that. There's some indication that pediatric survivors of brain tumors may be more at risk, but the literature is really mixed, which is kind of a common theme always, is the literature is mixed. We never have final answers. But a recent meta-analysis, which is essentially you take the results of all studies that have been done and statistically compare them to one another, and you can kind of get an idea of comparisons across these different studies in a really kind of scientific, mathematical sort of way that I don't fully understand. But essentially indicated that compared to typically developing children or typically developing kids, survivors of pediatric brain tumors were moderately at risk for depressive symptoms, mildly elevated for anxiety symptoms, no more externalizing problems, which is great. Our kids are not the kids that are going to act out necessarily. As a group, individually, some of them may, but as a group, they're not acting out. And then kind of moderately elevated overall distress. In terms of risk factors for these, history of posterior fossa syndrome or cerebellar mutism, those who had more neurocognitive concerns occasionally did report more psychological concerns as well. And then as we talked about with the social piece, who you asked mattered. If you ask a parent, if you ask the kid themselves, the parent saw a little bit more versus the survivor themselves. So it always matters who you ask. Our goal is always to ask everybody involved, but it does matter who you ask. So I want to switch gears for just a minute and talk about a place where you interact socially, and that's online. This is a place where a lot of our adolescents and young adults and our kids are interacting, and it's important to talk about. So more than 90% of US adolescents own or have access to a phone. My guess is it's probably like 99%. I think this data might be like a minute old. We use it frequently. We've all got it. I can almost guarantee there's someone in here who's scrolling social media right now, which is fine. There are a number of different platforms. They come out all the time. TikTok, Facebook, Snapchat, Instagram, Twitter, X, whatever it is, YouTube, online gaming, they all have kind of different goals within them. And the nice thing is it really can be an extension of a person's social network. So there's data to suggest that your online social network is very similar to your offline, but certainly allows different ways to stay in touch and do things and be in touch with people and connect. There's kind of a couple of different types of users of social media. There's your active users, they're posting, they're creating, they're asking for feedback, things like that. Then there's those of us who are more observers and we just scroll. It's a great way to kill some time. And of course, there's those, we do both. So in the media, and parents often comes up whenever you talk about social media, we fear for the risks. That's what we hear about. We hear about the risks. And I'm not saying there aren't. But I think it's important for us to consider the risks and not blanketly say it's too risky and therefore we can't do it because all the other kids are doing it. So we need to figure out how to help our kids do it. First is frank and honest conversations about social media when your kids are getting their accounts, or even if they already have your accounts. These conversations don't stop. Once you get an account, they should continue. What are you seeing? What are you sharing? The idea of impression manipulation, that what we post is often not the whole story. Filters run rampant, and some of them are really good, and you can't even tell that a filter has been applied. So that's understanding parental monitoring. That doesn't necessarily need to stop when someone turns 18, especially if you have concerns about kind of the developmental and social awareness of a kid, to be thinking about these things. Also need to think about the amount of time that we spend on it. Hours can pass without necessarily understanding how or when, but it's important to think about. But there are a lot of benefits. The first is really extending your social network. So especially if we think about some of our adolescents and young adults who, survivors who may have graduated from high school, live in small towns, don't have a lot of access to a larger social network, this can be a way to extend it. It can be a way to help with identity development, trying new hobbies, learning new things, finding a community. There's lots of different benefits here. Can also be a great communication tool. And this is a place where you can actually get extended time on a social interaction. Because if you're texting or if you are chatting or DMing or whatever it is, every platform seems to have its own thing, you can actually think about how to respond. You've got time to think. You can edit. You can draft. You can do all the things that you can't necessarily do in real life. And so for some of our kids, that may actually be really helpful as a way to meet others and meet some friends in different places. So there isn't a lot of literature on use of social media in kids with brain tumors and kids with cancer in general, other than the fact that we know they're doing it. But I did pull some literature on the use of social media in kids with autism spectrum disorders. And kids with brain tumors and kids with autism are not the same, but there are some similarities in some of the social challenges that we do see in kids with brain tumors, so it's kind of an apt comparison in some respects. And in both groups of kids, they were all using social media, every single one of them, so that's certainly not a question. But there were significant differences in what platform these kids were using. So your typically developing kids, they're using Snapchat. Or they were in this study a year ago. They're probably now on TikTok. It seems to change every 5 minutes. Snapchat is kind of built on social interaction. Kids follow each other. They're sending pictures back and forth. They're doing other things that I don't even understand. It's like one I refuse to get on. But it's a very interactive social media platform. Kids with autism were on YouTube. YouTube is passive. You're watching videos. You may be learning something. You may just be watching someone play a video game or watching somebody unbox something, which seems to be something that's very popular on YouTube, but it's very passive and it's very solitary. You're not interacting with people. You're sitting and watching. And that's something to think about when we think about our kids as well. It's that social motivation piece. It's what they're using and how. And it's the goals for their use of social media. So a similar study, this was 10 years ago now, but I think the idea is there as well. This looked at use of screen time and kind of use of kind of after-school hobbies, weekend hobbies between kids, typically developing kids and those with autism. You're typically developing kids in the lighter bars are on social media, and they're spending time with friends. Your kids with autism are watching TV and playing video games. Again, more solitary, passive activities versus your more interactive activities. So just things to think about. Okay, so for our last bit here, I want to talk about coping with these things. Because I don't have evidence-based interactions or interventions to talk about, I just wanted to talk about these things from more of a practical recommendations that parents and survivors can use to help. This is when I put my psychologist hat on versus my researcher hat. So again, developmental considerations, you need to be thinking about this, and we're going to run through this in some of the different areas as we think about kind of where kids are at different ages. So elementary and middle school, what's important? Your early elementary kids are seeking independence. They're really starting to pay more attention to friendships. They want to be liked and accepted, and they have that increasing concern and empathy for others. This continues into school age. Your third, fourth, fifth graders, friendships are becoming stronger and more complex, but there's also more peer pressure. There's more body awareness as puberty starts to kick in its ugly head, and attention span for many kids is increasing. Middle school, yeah, that's always fun. Increasing focus on the self, increasing interest in and influence by the peer group. Dating starts. I don't know if you've talked to your middle schoolers yet about dating. Still don't really understand what it means to have a boyfriend or girlfriend in middle school. My kids tell me about this all the time, and I don't understand, but they seem to enjoy it, and they seem to switch relationships about every 2 weeks. So it's a whole thing. School-related stress is certainly increasing in middle school, and so is moodiness. So that's super fun. Teens and 20s, as you get into high school, that's really, you see your adolescents really developing into themselves and their individual identities. They are still dependent on guardians, usually for a ride or money. Really this focus on fitting in socially. Most are still enrolled in school, high school, and executive functioning, and that frontal lobe is still very much developing. And the impulsiveness and the moodiness is still very much developing. So good luck to you. Your early young adults, kind of your 19 to 25, this is really when for many kids or young adults, I always call them kids and I feel bad, it's your emerging social and financial independence. Many are in college, graduating from college, graduate school. Others are looking to careers and jobs, and so really looking to step out on their own. Developing and maintaining committed relationships, so those romantic relationships are kind of solidifying, and that frontal lobe is still developing. Your late young adults, this is that settling down, and this is like a 15-year period, so this does not happen at 26. This happens over time. Again, furthering family and career development, financial autonomy, and there may be increased responsibility from being the one who's being supported to being one who is supporting others, whether that's a family or siblings or aging parents. So adolescence and young adulthood is a time of transition. And it's a time of very significant social transition, so I always like to talk a little bit more in detail about it. Friendships and romantic relationships are hugely important at this time period. Kids are almost developing their own families and choosing their own families, as well as staying connected to their family of origin. School and work are ever changing. They're starting, they're stopping, they're starting again. And again, that's just this time of transition. So if we think about factors that influence relationships, and especially social relationships and romantic relationships, there's kind of 5 big things that influence how we interact with other people. Mental health. If you're struggling with anxiety or depression, or other aspects of mental health, that is certainly going to influence a motivation to engage with others. There may be, especially if it's social anxiety, a lot of fear associated with interacting with others. Then there's physical health, how you're feeling. Our survivors experience a lot of late effects that influence their physical health. That doesn't end for them. Certainly cognitive functioning, as we've talked about. Personality, whether you're an introvert or an extrovert, is going to influence how you interact with other people. So if you are someone who gains a lot of your energy from interacting with others, that's going to be a lot easier than someone who needs a half an hour nap after spending 5 minutes interacting with other people. And then environment, so where you live, where you're spending your time, that is absolutely going to influence things. Okay, I am going to skip to this piece and then wrap up, because I know that we've got another panel after this, and I know we started a little bit late, so I wanted to skip to this piece. Actually, go back one slide. Okay, so the question always comes, as I said, I'm a psychologist, but I'm not your psychologist, but I've given some kind of tips and talked about some things, but certainly there's always this idea of what if it's not enough? What if there are things in your kid or your family where it's just the struggle feels like a lot, and kind of some of the practical higher level strategies that I've talked about today are not enough? And so this is where things like support groups, counseling or therapy, neuropsych or psych assessments and intervention come in. How do we find those things? I feel like that's always the biggest question. It's the biggest question I get as a psychologist. It's the biggest question I get as a friend sometimes. It's like, how do you do this? So at St. Jude, we had created a resource on how to find mental health resources in your own community, because our families go back to other communities. So I pulled some of that in here for you today. So how do you find a therapist? You could Google. Google's weird for therapy. It doesn't often work. Ask your doctor, ask your pediatrician, ask your primary care physician. They know the networks. They know who else is in their city. Call your insurance company. They have a list of in-network providers, and that can be a great place to start. If you're enrolled in school or college, talk to your counselor about school or local options. They often have a list of referrals. And then check to see if your local university has a psychology clinic. So when we go through our initial training in clinical psychology, we do it in department-based clinics that are very low cost. It's a trainee therapist, but they are motivated. So there's several different types of therapists, social workers, therapists, counselors, as well as psychologists. There's also options for medication management. There are a number of different types of therapy. They're listed here. You may have heard of CBT, cognitive behavioral therapy, ACT, acceptance and commitment, or dialectical behavioral therapy, behavior management therapy, as well as therapists that target special issues like trauma, sleep, or grief. Questions to ask when you're interviewing therapists, because please do interview them. Not all of them are going to be a great fit. What age range do you work with? If you're looking for a kid, you don't want to see someone who only specializes in those who are older than 50. It's not going to work very well. Do you work with people with medical conditions? Do they have that familiarity? What type of therapy do you offer? Do they have experience treating whatever it is the concern is that you're going to ask for things? What are your hours? If you need evening and weekend and they don't offer evening and weekend, it's probably not going to be a great fit. How long is your wait list? Unfortunately, y'all are probably familiar with wait lists. They are long. So often good to get your name on like 4 if you can. Do you accept insurance? Many don't, but we'll give you receipts and bills that you can then submit to your insurance company on your own. And then do you offer telehealth? That can be a great way to extend the reach within state. So I'm going to wrap up here. My contact information is here on Twitter, email, and then my website at St. Jude. And then I always like to end with cute dog pictures, because when you talk about funny, hard things, cute dogs kind of make it better. So I will end there. Thank you very much for listening. And I don't think we have time for questions, but I'll be on the panel at the next one, or you can find me outside. Thank you so much.
Good morning, everyone. We are so excited for this next session. I'm Stacia Wagner, president at Children's Brain Tumor Foundation, and you just met Dr. Willard. We'll give our experts a chance to introduce themselves, but we know that this conference is all about bringing experts in to talk about what's going on, and we truly have the experts here today because nobody knows better than the family members. We know a brain tumor diagnosis impacts the entire family forever. And after working with teens and young adults for the past couple of decades, I know sometimes there are things that siblings, survivors don't want to talk to their parents about. And you often hear, my parents are already so burdened, so worried, I don't want to give them something else. Or you're just at that age where your parents aren't the ones that you want to talk to. So we want to ask these experts for an inside view of their perspective of the brain tumor journey. So we'll start with you, Sahil, if you want to introduce yourself and tell a little bit about yourself.
Hi, everybody. I'm Sahil. I'm from Fremont, California. I'm 15. And my story is that when I was 8 years old, my brother was diagnosed with DIPG, which is a really rare brain cancer. And he passed away when I was 10 years old, so after 31 months almost. So he fought really bravely for 31 months, and I was there throughout the whole journey. And I would just want to say that I think siblings are definitely a really important part of all of this, and I'm really looking forward to speaking more on this topic.
Hello, everyone. My name is Noelle Gonzalez Jackson. I'm 16, and I'm a senior at the Academy of Health Sciences at PGCC, a long, long name. But I'm also a sibling, and my sibling was diagnosed when I was 8, too. And she was diagnosed with juvenile pilocytic astrocytoma, and it metastasized to her spine, and it was sort of like around her optic nerves, like optic chiasm, right where they meet. And I was sort of given the language, like those technical terms, to explain what was going on to her, but it took a while for me to actually conceptualize exactly what was happening to my older sister, who I was so close to, and I still am.
Hello, my name is Sophia Posner Brown. I am 16 years old. I am a junior at Jackson Reed High School. I am a survivor of brain cancer. I'm not exactly sure which type it was. I know it was some form of astrocytoma. And I'm looking forward to speaking about that.
So you started to introduce where you are in the brain tumor journey, but thinking back, and I know, Al, you sounded like a doctor saying that, but thinking back the first time you heard the word brain tumor, tell us about that experience and how it happened.
I think for me, the first time it happened was the day my brother went into the hospital. That first day when he was diagnosed, I was only 8 years old, so I went later that day, and then I saw him hooked onto all of the machines and all of the tubes and everything. I saw him on the ICU hospital bed, and I think at that point I realized this is a lot more serious. And later that day, my parents sat me down and they told me that he's really sick, and I think they explained it in a way an 8-year-old can understand, because obviously they can't use all of this advanced knowledge. But I think over time, as Noelle mentioned, I started to conceptualize a lot about what my brother was going through, and through listening in through all of the meetings for doctors and nurses, through seeing my brother, seeing his journey, I definitely realized what he was going through. So I wouldn't say there's one defining moment, but throughout the entire journey, I just put the pieces together and I realized the scope of what he was going through.
I really like how you explained that, because I definitely relate. I remember it was May 21st, it was a Wednesday, and I remember Mia, my sister, had an eye appointment, and so she was just going to the doctor with my dad, and I remember getting a call, what is it? Yep, that's what, we went to my neighbor's house, and that's where I was staying while Mia had her appointment. And I was supposed to go home at the end of the day, but I was still playing video games and eating a Nutella sandwich, and it's like, it's really taking them a while. And so I remember my neighbor got a call, and she sat me down. We were in her car and about to take me home. She said, "Have you ever heard of a brain tumor?" I said, "No." She said, "It's sort of like part of your body is trying to attack another part. And like that's what's happening to Mia." And it did. It took me a really long time to sort of piece together everything. And I think part of it was that I didn't see Mia really in the hospital. And I think my parents, I realized looking back now, there are a lot of different ways to handle this event, because before your kid has cancer, you are not a cancer parent. You are just a parent, and you're just trying to navigate having a child or children. And it wasn't until I started to reflect more that I realized how unique everyone's journey is. But yes, it was definitely, it was very strange hearing like, what is really happening? And I wanted to know like, okay, but why did this happen? We didn't really have the answer, and how are we going to stop it? We didn't really have that answer. And it was just like the first time I really had to think about, we don't always have the answers to everything. And that was a hard thing to wrap my head around.
Well, I can say that my experience was definitely pretty different. I was diagnosed when I was 2, so I don't have many memories of it. It's more that it was an issue for my parents. They have all the memories. So I don't think there was ever really a time when I was going through treatment where I was like understood what I was going through. I think it more happened after I was done with treatment. I was feeling better. I was starting school again. That's when I kind of started to understand what a brain tumor was and what had happened to me. Now I know, but I definitely can say I didn't know when I was that young, and I wasn't as worried as everybody else was. I was kind of just living my life as a kindergartner, not like really focused on what was happening to myself and what could easily have happened if it had gone worse.
You guys are so articulate. I'm so impressed. So tell me this, what has it been like for each of you being a part of a family that's impacted by a brain tumor?
For me, it's impacted me in so many ways. I can't even begin to describe. Like when my brother was diagnosed, like he stayed in the hospital at first for like 4 or 5 months. He was just in the ICU, and I think that really changed me, you know, seeing at such a young age, being at the hospital almost every day, because my grandparents would like drive me to the hospital after my school every day. Then I'd be with my brother for a couple hours, and just seeing him and then seeing all the nurses, seeing all the doctors, that really changed me. And I feel like that really matured me from a young age. And I feel like a lot of siblings, when they go through that experience of staying at the hospital and seeing their siblings and seeing their parents help their sibling who's going through cancer, I think it really matures them and really it grows them from such a young age. Like a lot of other young kids don't experience this. And even after that, during the journey, I think I gained a new sense of how life is like so important. And I realized, like, from my brother, he fought so bravely. He never said, "Oh, why me? Why did I get this?" And he was always looking up on the bright side, on the positive side. So I think that really helped me become more of the person I am today, for me becoming more optimistic, more bright-minded. And even after his passing, I feel like his legacy, like, he's still inside of me, and this has made me want to do a lot more. His journey has really like inspired me to be a voice for other siblings and just do a lot more for cancer. And I've gotten so many experiences and opportunities for networking that I wouldn't have gotten if he was not diagnosed. But obviously I wouldn't have wanted him to be diagnosed in the first place. But it has really changed me, and I feel like I've grown up a little bit quicker in a sense.
Yes. I think my sister and I were always sort of mature, but her diagnosis really changed everything. I'd say it's hard to sort of compare because you never really know exactly what it would have been like if she was never diagnosed. But I think just trivial things don't really matter as much. You realize that your classmates are sitting talking about they want this pair of shoes or they want this and that, and you're like, well, my sister's dying right now in a hospital bed. And I actually did not see my sister. I saw her twice over the scope of 3-4 months when she was in the hospital. And my parents thought hard about that decision. They knew that my sister, anything that could go wrong, it would go wrong with Mia. She had a brain bleed when they first tried to get a biopsy, and so then she had all these tubes literally draining. I thought it was pink lemonade at 8. I was like, what is that? Is that coming out of her head? What? And it was so strange just seeing this, my sister, who was always up and jumping, and I was more energetic, but out and playing, and now she's bound to a hospital bed, and the tubes and the beeping, and I remember counting how many meds she was on. It was 32 or something, and it was so strange just seeing her. And I remember how foreign it felt, because I reached out to touch her hand, and she squeezed it back, and I was so excited. It's oh, she knows I'm here. But she wasn't able to respond. And so I really quickly started to treasure the smaller things a lot more than I was before. And I think that's really what this experience teaches you. It's the small things that matter a lot more. And even though, like you said, you didn't really recognize, because you were too, you really start to value things when you look back.
Yeah, I think you really start to be more grateful for a lot of things, even the smaller things in life, and especially you mentioned, if your friends or any trivial or small thing doesn't really matter. Even today, all my issues my friends talk about, all the small issues about grades or about classwork or anything, at the end of the day, it doesn't matter. It's about what you have right now, and it's about the family you have right now, and you should always treasure those moments. So I think my brother's diagnosis has really made me become more sensitive and more grateful and more appreciative of all the things I have. Yeah.
I think I would say that now I definitely feel now that I have a clear understanding of what I went through, I see how I should not take anything for granted, and that it so easily I could not be here today, and that since I'm here, I should just really be happy that I'm here. And I have a twin sister, so that was definitely a struggle for my parents and for everyone, is dealing with a kid who's sick in the hospital and another child the exact same age who's just dealing with going through school and dealing with being a child, and thinking that she's not getting the same amount of love because the parents are always in the hospital with me. So we had a nanny, which made everything a lot easier. But I definitely can say I'm super thankful for my sister, and she's made everything easier. When there were the few times where I would remember my treatment or would remember side effects of the treatment, she was there to help me through it. And I think that's made my experience a lot easier, is having someone who doesn't know exactly what I'm going through, but who has been there through the whole thing, so can help me through it.
Well, you can definitely feel the maturity and introspectiveness of each of you. Thank you for those real pearls of wisdom that it takes some people a lot longer in life to learn. So thinking back, is there anything that you wish you would have had or known, or I know whether you went to the hospital to see your brother, those types of things, anything that when you reflect back, I could have used some support here, or this would have been helpful just in reflecting?
I would say in reflection, I don't think that, obviously I wouldn't have wanted my brother to be diagnosed in the first place, and I didn't want him to have cancer in the first place, but I feel everything that I went through, I think it shaped me the person I am today. And obviously, if I had known this, I would have wanted to spend more time with him before his diagnosis, spend more quality bonding time. But I think everything I've gone through, it's made me become a better person. I wouldn't really ask for anything more because all the struggles that I went through, but especially my parents, seeing them go through the fight and seeing my brother go through the fight, from being in the ICU bed to slowly walking, slowly regaining his ability to walk, talk, eat, feel, and him going back home, and then seeing that whole journey, that has really inspired me, that has really changed me. So obviously, I would have wanted to spend more quality time with him, but I feel like this whole experience, I don't really want to change it. I just want to look back on it and take the lessons I've learned from it.
She's so well spoken. Yes, that's exactly it. I think, like, looking back, I really have to give it to my parents. They did so much research. Like, my parents work really well in crisis situations, which is like, you don't want to have to use those skills, but they did really work out here. I remember my mom and dad would say, like, well, we're reading this book about cancer and like how to treat the siblings, and they would watch videos and speak with the doctors, and they would do all of these things to make sure that they were as engaged and involved and prepared as they could be. And through that, they really focused on how do you take care of a sibling during this time. And I remember sitting down with mom and dad separately, or both of them, and they told me what was going on, and they told me, you know, this is a time where you might not be getting as much attention, and it's not because we don't love you, it's not because you're doing anything wrong, it's because your sister's really sick, and she does need that special help. And one thing that I really appreciate that they did, like, so I don't think, like, we didn't have a nanny, or we didn't have like grandparents, but we had, my parents would switch off every day. So one person would be at home and one person would be at the hospital, and my mom was super organizing mom, and she had like a whiteboard with everything, and we knew exactly what was happening. And that routine really helped, I think, at that age, and not fully independent. I think having a set schedule was great. I think having another sibling to talk to would have been really nice. I remember having a lot of adults come, and we got so many presents. We got so much food. Like, to me, like, cancer was great because we got so many snacks. But no one really knew exactly what to say. They were like, oh, I'm really sorry. Let me know if you need anything. But I was 8. I was 9. I didn't really know what to tell them. But I think if I had another sibling or a survivor to talk to and say, okay, this is what to expect, I think that would have been really, really helpful, like a mentor. Yeah.
I guess speaking more for my parents, I'd say that I guess what could have been helpful is more information, more like people talking to my parents, not only about what I was going through, but what they could need, what they could use help with. Instead, it was always about my treatment, and always normally the bad things. Not enough good things were being said. And I think that's definitely a huge part, is that people need to talk about the good things. People need good things to look forward to, not just all of the, oh, well, this could not work, the surgery could turn out bad and she could die in surgery. That's not what people need to hear. People need to hear the small chance of good hope, because in the end it can happen.
That's a really good point. And you've already started dispensing some wisdom and advice for others. And I think what we all want is to make sure that we can take this back with us, and for other siblings, other survivors, medical providers. We know some insight. So what advice would you give to another sibling?
To another sibling, I think the main thing is just be yourself around your sibling who has cancer, because at least in my case, when my brother got diagnosed, I really stayed true to myself. I didn't really change the way I acted around him. I still, especially after he got out of the hospital and after he was back home, I just was myself around him. Like even before diagnosis, I acted the same way. Even after diagnosis, I acted the same way. I joked around with him. I still like annoyed him, teased him, made fun of him, and it was just normal things brothers do, like played video games together, hung out together. So I would say that just try to be yourself and don't act different around them, because if you act different, then they're gonna feel like, oh, why are they acting different? So just be yourself and always look out for them. Look out for them, obviously, but just continue the things you've always been doing. I think that's really important. And that way you're gonna continue you're gonna continue all the normal parts, and you're not gonna make that other sibling feel like, oh, why is like my sibling acting different around me? So just be yourself. That's my advice.
That, yes. I'd say be yourself and be patient. That's one thing. I'm looking at my mom. She's like, yes. It's one thing I was not very good at all. I remember I definitely treated my sister the same, and I really stepped into my caretaking role. And I didn't realize how much I would enjoy doing it. We always joke with my parents, like, you all are just gonna get a nursing home. I'm not wiping anyone's down, not changing any diapers. But I realized I really did like taking care of my sister. I remember she would often get very sick and like nauseous after chemo. And so I would help like get the bucket and rinse it out and just like rub her back and those sorts of things. And I think that really brought us closer. And I think it still gets me sometimes, but the patience when it comes to the symptoms of brain cancer, particularly executive functioning, that was something I really did not understand. I was like, but this is the same Mia. Like, it was Mia after the brain tumor, but I didn't really realize that her brain chemistry changed and different wires are crossing different ways now. And so I have to be more patient. There are times when I would just interrupt her and say, like, why do you not understand? Or just keep asking her questions. And she'd say, it's too much. Like, I just need a break. And I would not give her that break. And that's one thing I really regret. And I'm glad we've come a lot further. Because I did hold a lot of guilt for that. Once I realized like how mean that really was, is as much as you want to stay true to yourself and be the same sibling you were, you do have to approach it with caution. Because this is a new person in a way. It really is. Like sometimes we talked about, like, I did miss Mia before the brain tumors. I did miss some parts of that. Because it's not an easy journey at all. And they really do, like survivors, it's a really big change for everyone. And I want to tell a sibling that look out for that and be ready and be patient.
That's great. And what advice would you give a survivor, Sophia?
For other survivors, I'd say, like they said, just really be yourself. Since I was so young, I don't know if I can give like concrete advice for people my age now about how going through a brain tumor would be, because I don't have that experience going through it as a teenager. I think that's much more challenging, and it would be much harder to be yourself. But as the age I was diagnosed, I was a child, so I didn't quite understand what was going on. But now I still have a lot of side effects from it. So I would say don't let that control you. Like, still do everything you love. I still do everything I love in school and outside of school. Even if I'm struggling with the pain that I feel, I don't let that stop me from doing other things I want to do. And I think that's just the main thing, is you can't let your side effects or your brain tumor be your whole life.
I think one thing I want to add on is that if you're a sibling, I think that your sibling's diagnosis, it shouldn't stop you from doing the things you love, like following your dreams and whatever hobbies you like to do. You still continue to do that, because in my case, even though it was like in a even though he fought for 31 months and we were like in between hospitals or we were at home sometimes, or sometimes we had to go to Mexico for some treatments. So even though like my parents and my brother, they were bouncing around from one place to another, I was always really interested in art, so I always continued my art hobby. I always continued that passion. So I would say that if you're a sibling, just don't let the diagnosis stop you from doing the things you love, and just remember that your brother or sister would have wanted you to follow your dreams. So just don't let that stop you.
Thank you all. So that was advice for siblings. And you guys have talked a lot about your parents so far. But what advice would you give to a parent who's starting this journey?
I would say for a parent, one thing my parents did that I felt like I observed it, just looking back on it, I feel like that was like really good of them. But one thing my parents did was that after my brother's diagnosis, they always asked Ronnie that, before any treatment or going into any hospital or doing anything that would affect him, they asked him, are you okay with this? Is this okay? Do you want this? So I feel like just talking to your kid, because I feel like kids, they understand a lot more than what we give them credit for. They understand, they're a lot more mature, especially at talking with these things, because I feel like they don't understand how like serious this is. They're able to communicate more about it, and it's not as sensitive for them. So just open up to your kids about like what you're gonna do, and always ask them, because my parents were always like very vocal with my brother about his diagnosis and everything that they did to him, like all the treatments they went to, and they're very upfront about it. So that's one part of it. And I would say afterwards, when my brother passed away, my parents, I'd say one thing is that after your child passes away, don't impose your grief on another family member, or don't try to say that, oh, because I'm crying, you have to cry, because everyone grieves differently. And I think this just goes to like, it's just general advice for anyone, but you should always respect how other people grieve, because everyone has their own ways. So yeah, that's my 2 pieces of advice.
I like that. That makes me think. My sister is still alive, and that's one thing I think that's really hard for parents to sort of wrap their heads around sometimes, is what it's really like to be a survivor, what it's really like to be a sibling. But they never really get the chance to ask themselves, what is it like to be a parent? Because I think we all sort of take these things as they come, and it's just a part of our life. But you need that time to sit down for yourself. And I'd say one thing I'd wish for all parents is just a second to just take a deep breath and recognize that you are doing the best you can with what you have. And that's all anyone can ask for. There's so much pressure to do right by your child. And I think there's only so much we really know. Like that your parents said, like, are you okay with this? Because it's that whole consent. That's what really matters. But I'd say be open to the new opportunities that this might bring. I'd say, like, as a sibling, I would have never really explored maybe this whole field. But now I love the medical field, and I'm really interested in pursuing it. And I think some parents might be the same way. My mom is very good at comprehending like medical language and being able to break that down, and especially simplify it for younger audiences. And that's a strength that I think maybe that could be a job that you could pursue. And there's just so many things that I feel like there's so many things in the moment going on. So I'd say for parents, remember to slow down, remember to take care of yourself, and reach out to anyone who has gone through the same thing, because those people will be great resources for you and for your family. Like CBTF, Childhood Brain Tumor Foundation, you all really provided access to so many different programs, I think, for every individual in the family.
And I just want to quickly add that just from my personal experience, like seeing both of my parents, like they were when my brother was first diagnosed, they were in the hospital like nonstop for 4 months. Like my mom did not leave that room for 4 months straight. And I think that really inspired me, and that really like shook me that my mom has not left my brother's side for so long. So, and even after, like during the 31 months, they were always beside my brother, and I think I was with them too. I was always tried to be with my brother as much as possible, but I think you should always, as Noel said, take time out for yourself as well. That's really important, because if you are not taking well care of, then you're not going to take good care of this your child. So just look out for yourself and take a deep breath.
I really agree with both of those things said. Like, my parents were very involved. They were always with me, either switching off and on or at home with me, because I never was, I mean, I was in the hospital for a while, but I never had the issue where I was there constantly, every day, all the time. I would get to come home after a couple weeks. It was never like multiple months. So I had that, which was good, so I could still see my siblings, I could still see my friends. Well, I was very young, so I didn't comprehend my friends, really. But it was, I think that my parents needed to be able to come home. I think being in the hospital, they should not have to be there all the time. Even though your kid's in the hospital, you shouldn't both have to be there constantly all the time, because it's not a fun environment. It's not fun to be there every second of every single day and never have a break, which I think is what parents really need if they want to keep going. They can't just hold all their feelings and have another kid at home who you don't know how they're doing. You don't know how they're doing in school. They're really being taken care of at that moment by the nanny, which is really good that we had that. So I think really they just need to step away and be able to say, this is too much for me.
So, from your perspective, what advice would you give to medical providers? Even thinking about if that's your career path, what have you learned that you could say to a medical provider, this would be helpful for families?
I would say that, especially since I went to the hospital frequently, I listened into what the nurses said, what the oncologist said. I really after a while, I started to understand like how they talk and everything. And I would just say that, especially if you're dealing with children, be more empathetic and be more sensitive, because especially with my brother's brain tumor, DIPG, it's 0% survival rate. There's no effective cures. There's no treatments. Cures, obviously, no treatments for it. And our oncologist was not very supportive. So I would just say to treat every case, especially with the kid, with a lot of compassion and a lot of empathy, because at that point there's not much you can offer except your support. And the parents, they're really vulnerable at that time, and they're basically at your mercy, because if whatever you tell them, they're going to do it. So you should really try to be sensitive with them. So yeah, just try to put yourself in their shoes, that if I was a parent, how would I feel? How would I want my doctor to be? So that's the advice I would give.
Yes. Wow. Yes. I think as a medical provider, I wish you would be able to put yourself in our shoes. And I think all of our doctors were very good at that. They always gave the advice, like, if this were my child, this is what I would do. And I think that's huge, because we're so trusting. Like, that's, your baby is in their hands, and you want to do right by your child. And I sort of think, okay, well, how do you compartmentalize that? Because I think after COVID, we realized, oh, we're really burning out all of our doctors. That's a lot they have to see and a lot they have to go through. So I guess it is a big ask, but it is very important to empathize and to not underestimate the parents and the families. And I think that's huge. A lot of the times, some internal biases might enter the space, and you say, oh, I don't know if this person will really understand this, so let's just go with that. But please, take the time to explain. Take the time to break it down and answer their questions, and maybe suggest some questions that other people have said, because we want to know exactly what's going on, and information is truly powerful.
Yeah, I think what you just said, it reminded me of one experience where when my brother was first in the hospital, Ronnie, he was on life support, and all the doctors told my parents, take him off life support. Like, he only has a week to live. So there's nothing you can do at this point. Call whoever you want to call, but there's nothing else you can do. But my parents, they kept hope, and they realized that, no, we want to continue to keep him on life support. Even if there's that 1% chance he can still make it, we're betting everything on that chance. And obviously he did end up waking up, and he was able to walk, talk, and do a lot of things that the doctor said he would never be able to do. So I think that this just goes to show that obviously the doctors need to follow everything in their textbook. Like, if DIPG, if it's 100% fatality, then yeah, they're gonna say that you have no hope and just go home and make memories. But I think leave a little bit of room for optimism. Don't ever say that, okay, this is what you should do. Like, always consider alternatives, consider like possibilities, and miracles can happen, as you just saw with my brother. So just keep that in mind too.
I think that it definitely is hard for doctors to navigate having so many patients and having so many patients who don't really survive, which just takes a toll on them in general. But I think, like everyone else said, they do kind of need to kind of put themselves in your shoes, so they're not just insensitive and just telling you a script, basically. They need to cater it to each family, I think. And I believe that I had some good doctors, even though I know that my mom and my dad sometimes wouldn't always agree. There were some times that were hard, but like Dr. Kilburn and Dr. Packer were the best, and we still see them every time we go to the hospital, and we love them. They were always helpful, and they were definitely two doctors who we really saw who would make connections with me, who would not just try and get me out of there. They really talked to me and asked me every time I see them, even though I don't see them that often now. Every single time I see them, they ask me how school is going. They ask me how my life's been going. I think that's a really important part, is making connections with your patients.
Yes.
That's great. I think we have time to open it up for questions, but I just want to ask if the three of you want to travel the country and go to hospitals and provide this education, because it's pretty priceless what you're saying, and it's a nice reminder to all of us about treating each family individually and with compassion and empathy. So thanks for those words of wisdom. Well, we have about 10 minutes if there are questions out there or comments.
There's a mic at the back that will be brought to you if you have a question. If you want to raise your hand. Someone's got to be first.
And Maria,
We
it's
got
being
one.
recorded, so I need to be more patient. We have that.
Hi, my name is Marie Finn, and my daughter Vivian died 3.5 years ago, and the siblings are still a little angry, and they don't really like to get involved in, say, events that I would host for Vivian. What would you say to them? And I do want to give them the space to grieve properly, and I think also they sort of feel like, oh my God, I'm the freakazoid who is the sibling of the girl who died from DIPG. What sort of advice would you give me, a parent, to not force them to do it, but just give them the space? What could I say?
I think I can go first. So after my brother died, I immediately, I went to counseling and I went to therapy. I think that was really useful in me expressing my feelings, because my parents, they were grieving in a different way, and I didn't really know how to talk to them. So I feel like therapy and counseling, that for me, that really helped me recover. And I think that I was always like a really positive person, and I think after that I grieved like in a positive way. I always look back at the happy memories with my brother, and I always look back at the optimistic moments, all the good moments. I didn't really focus on the negative. So my advice would just be to remind them of the good memories, and and to consider like counseling or therapy. I don't know if your kids already do that, but that was really useful for me. So yeah, if anyone else wants to add anything.
I just want to add one thing. Another foundation that I love is Special Love. I don't know if you've heard, but they have, I can get you the information, but they have an amazing program for siblings, and they actually have a week-long camp in the summer, and it is the most fun week of my year, and it feels like Camp Magic, and it feels like home, and there's a special chat that they do for bereaved siblings, and it really hit home for a lot of people. And I'd say it gives kids those organic like friendships that they'll eventually talk about it, and they'll be able to have space to have those conversations. And I think once kids are able to speak to other siblings who have been in the same position, they're able to start. They open up, and you'll probably see some sort of difference for sure.
I would also jump in and add, I think what you said earlier, that everyone grieves really differently. And so for some that grief may feel like it needs to be a call to action, and I need to memorialize, and I need to get out there and change the world in order to memorialize. But for others, it may be, this is very private. And so my grief needs to be private and for me and for myself. I think also too, and you guys may know this, given that you were young when your siblings were diagnosed, we grieve differently at different ages. And so there's sometimes a re-grieve or a re-understanding or a new understanding of what happened and how I can change things as you get older. So if they're 10 now, and then when they're 15 and when they're 20, they may feel very differently. So I think maybe keeping that space open for them, that they always have an open invitation to participate as they want to, can share why it's important for you or for whoever is participating, why it's important, but an understanding that there are different ways.
Thank you.
Any other questions? Okay, I just want a huge round of applause for your honesty, your wisdom, and we could just hear the immense gratitude you have for your parents. So to all the parents out there, like one of you said, there's no book on how to do this, so you're all doing a great job and leading the way, so thank you to all the parents.
And as they said, take a breath.
Okay, I think we have a break for a couple minutes, and then we are going to, Ethan and I are going to talk about education and career impact. Yeah. Okay.
Okay, thank you all.
Thank you.
Thank you.
You guys are the three most impressive.
All right, you guys, we are to lunch. And you know what that means? You all are like herding cats in the lunchroom. I feel like my mom used to be the lunchroom monitor in my school. And I feel like that's what I'm doing today. Y'all come in, sit down, be quiet. No, we are so glad you're here. This is going to be a fast-moving, super fun luncheon with some of the best people I could bring to tell you about where we are on the cutting edge. Before we talk about the power that you have, which is what we're going to talk about at lunch, we're going to talk about those that came before us, and some of you might have been in that in the last 5 or 10 years. We're going to go to what makes patient advocacy the secret sauce to combating childhood brain cancer. That's you guys. I hope you're paying attention. You are the secret sauce in the way we're going to move forward. And so we're going to give you some examples. We have a great panel today. But before we get started with where we're headed, we really need an appreciation from where we came. And so I am bringing up to the stage my friend Dean Crow, who is the founder and CEO of Rally Foundation for Childhood Cancer Research. She is a DARPA partner. She is a strong supporter of the Brainstorm Summit. And I can't think of anyone better to tell us where we've been because she's been there through it all. Thank you, Dean.
Thank you, Lisa. If I haven't had the chance to meet you, I'm Dean Crow, as Lisa said, and I am the founder and CEO of Rally Foundation. And just a little bit about Rally, if you don't know about Rally, it all got started with a simple question. My husband was coaching a baseball team, and one of his players was diagnosed with a medulloblastoma, and we started getting involved. And when I saw what that family was going through, I said to his mom, "What can I do to help you, and I will not make you dinner?" And Rally now exists because of that, because she said raise money for childhood cancer research. But just thank you, Lisa. Your vision for bringing together the brain tumor community is absolutely amazing, and what you have done is phenomenal. And thank you to all that are in here who are part of the grassroots, who are parents and patients, and that you really care about this. And then thank you so much to the farmer that's here, to the government officials that are here, and to the companies that are here. Thank you for caring about kids with cancer. So Lisa asked me to really quickly, we're kind of trying to hone this down a little bit more than we were, so to really quickly kind of take you down a trip down advocacy lane. So what we're going to do is we're going to look at making the secret sauce. We're going to look at battle cries, we're going to look at the successes, we're going to look at strategies, and we're going to look at what's on the horizon. So battle cries. There was a real battle cries. If you can get the community saying the same thing, it will be such a powerful voice. So there was a battle cry that came together several years ago, and it was more than 4. We wanted the government, we wanted specifically the NIH to give more than 4% to childhood cancer research. Y'all, they're giving 8%, so give it up. So our battle cry more than 4 is now outdated because they're given 8%. So, of course, now we want more than 8. But we need to be sure we say thank you for that increase. There was a battle cry that was unifying, which was Go Gold. An organization has trademarked and has exclusivity over Go Gold. So now the childhood cancer, several of us came together, and we trademarked Gold Strong, which is open for anyone in the childhood cancer community to use. So please use the battle cry, Gold Strong, and then also for this, use Brainstorm Summit, and the unified voice will have a great power. So let's now continue down advocacy lane, and we're going to look at our successes. Now, let me just say this. Have you heard of the 10,000-foot view? Raise your hand if you have. Okay, this is going to be the 100,000-foot view. We're going to go that fast. So you're going to be way up high, and we're going to go through that. So the first one is the Creating Hope Voucher. And that was led by Nancy Goodman of Kids First Cancer. And then it was passed into law in 2012. It was reauthorized several times. It has approved 34 pediatric drugs for rare diseases and 2 specifically for childhood cancer. 65 vouchers have been issued and 39 have been sold. Currently, those vouchers sell for $100 million each. Next down advocacy lane, we have Gabriella Miller's Kids First. It is led by Ellen Miller of Smashing Walnuts. It was passed into law in 2014. It authorizes $12.6 million each year for 10 years for a web-based facing pediatric portal to collect data. There are more than 50,000 data sets that have been collected. There are 6 Kids First portals, including the Children's Brain Tumor Network. All of that passed in 2014. We're going to hear more about that later. We have the Race for Children's Act, again led by Nancy Goodman with Kids First Cancer. It was passed into law in 2017. Thank you, Greg, for your help. It was fully implemented in 2021. What this allows for is drugs that share the same molecular cancer target triggers an automatic study for a lot of the drugs in pediatric cancer studies. This provides more drugs for our kids. The DoD PRCRP, led by myself with the Raleigh Foundation, we have increased since starting our advocating in 2017 was the first year we were eligible. We have gone from $19 million at the Department of Defense to $144.4 million, which is a 758% increase. And I just want to give a shout out to this table over here because they really help, so thank y'all. The STAR Act, which was led by Daniel Leach and Sarah Milberg, sponsored by St. Baldrick's, and then a lot of support given by the Alliance for Childhood Cancer Research, passed in 2018, was reauthorized last year. It's $30 million each year for survivorship, treatment, research, access, and research. CCDI, thank you again, Greg, from the State of the Union. It was part of the 2019 State of the Union. It is led by the NIH. What it does is it allocates, it's been funded since 2020, it allocates $50 million a year annually for 10 years for childhood cancer data collection. So what did these successes do? They each did something a little bit different. They provided incentives to pharma companies. They reallocated and redirected some federal funding that was already out there. They appropriated new federal funding, and they expanded research, all to advance childhood cancer research, but all very differently. What's Raleigh's 5 top ingredients to the secret sauce? Number 1, you have got to have your data. You have to have the facts. It is imperative that you know and you can back up what it is that you are asking Congress to do. Number 2, this will be a newsflash. Everyone wants to get to the member. Newsflash, their staffers are your BFF. The staffer, granted, someone said this yesterday on a panel I was on, the member is the head, but the staffer is the neck that turns the head. You want the neck. And if you win over the staffer, you are going to have someone who will really advocate for you to the member to support your legislation. Super important. You have 15 minutes to tell your entire story. You have 15 minutes with the staffer. Okay, here's another newsflash. Our country is run on 15-minute meetings. That's just a fact. You get 15 minutes, and you've got to say your hellos. You've got to share your story. You've got to make your ask. You've got to present your data, and you have to leave time for questions, and then you need to leave because they have someone else right behind you coming in. And so it's very important after you keep your message simple and you tell them what they need, that you do your follow-up and that you follow up with emails and phone calls to the staffer. You want to make best friend because you want to call your best friend. Your best friend wants to hear from you. It's very important also that you be professional when you are in these meetings, that you dress professionally, that your presentation is professional, and that your materials are professional and understandable. And you also want to understand the advocacy landscape. You do not want to go out there and be asking for the same thing that someone else is asking for. And so the way you do that, the way you understand the landscape, is that you collaborate and you hear what everybody else is doing and you work together, and it makes us stronger. So what's on the horizon down advocacy lane? Right now, there's a bill called Access to Care. It is led by Matt Marks of the Leukemia and Lymphoma Society. You can see it's been introduced in the House and in the Senate. It will allow kids on Medicaid and CHIP to cross state lines when treatment is not available in their home state. Give Kids a Chance Act, led by Nancy Goodman with Kids vs. Cancer. It's been introduced in the House. It will allow the FDA to direct drug companies to test novel drug combinations and novel and existing drug combinations. The Finn Sawyer Access to Care, led by Brandy Lee and the Shepherd Foundation. It will require molecular testing at diagnosis on all cancer patients who have Medicare, Medicaid, and CHIP. Currently, they molecularly test at relapse. Might be helpful if you did it at diagnosis. Kids First 2.0, super important. This is, again, led by Ellen Miller of Smashing Walnuts. It has been introduced. They are advocating for a 5-year reauthorization. This is something that y'all can all support. The PRCRP, led by me, every single year, we have to go back and ask to retain our report language and to increase the funding in the PRCRP. Now, you may, as you see, we started advocating for the inclusion of cancers in children, adolescents, and young adults, and got a lot of other topic areas added. Originally in was pediatric brain tumors and neuroblastoma. We started advocating for more funding and additional topics, and you can see starting in 16, 17, and you can see how our funding has increased. And I'm thrilled to tell you that if you look at 16, there's 6.5 million. Some of that was neuroblastoma, some of that was pediatric brain tumors. Since we have been advocating from 17 to 22, $30 million for pediatric brain tumors. And super fun to work on that with my friend Danielle. Rally sees itself as philanthropic seed investors in the next great discovery. So you may be saying, why do you want more money? We see ourselves as philanthropic seed investors in the next great discovery. We make our grants through Proposal Central. Through Proposal Central, we have given about $25 million to fund childhood cancer research. We know that our research is making a success and that it is growing. Because you can tell from this slide at Proposal Central, our $25 million has resulted in an additional $500 million of funded research. That research is that big because it is federal funding that we need. I can't tell you the phone calls I get from researchers that say, I just missed the pay line. So that means very good vetted research is not being done because we don't have the federal funding. So we have to advocate every year at the DOD that we increase the PRCRP budget so that we can have more money for funding so that our kids can have better treatments. We have you have heard from 2 DOD-funded researchers, or you will, Robert Gattel and Elias Sayor. But the main ingredient to our secret sauce are the kids. And you don't ever want to forget that. Excuse me. So last year, at this time, I was headed to the White House with Rally Kid Caroline Belcher, who many of you know. And as you know, she lost her battle earlier this year. So I wrote her a letter about being here. Dear Caroline, oh, sweet, strong girl, I miss you so. I miss our Zooms, I miss your giggle, I miss your hugs, and I miss our bond over being so small and talking about being late bloomers as teenagers. As I was getting ready to go to DC, I kept thinking how much we were together last year in DC, how all things considered, you were seemingly doing great. We kind of knew that wasn't completely the case, but you just looked so good and you were so full of life. It's just hard to know that you aren't here. You won't be at the White House or on Freedom Plaza or just hanging out in the lobby of the JW. There's a gaping hole that's ever present because you're not here. But what do I miss most? To be honest, sweet Caroline, I miss most are our conversations over Zoom about the need for childhood cancer research. We talked a lot over Zoom, and I was always impressed with how much you put into our conversations and your answers. You have been through so much in your 14 years, diagnosed with a brain tumor at just 3 years old. You were wise beyond your years. And because you were petite, the nice word for us short girls, you seemed younger than you really were, which was an advantage when you talked. I am forever grateful to Dr. Ted Johnson in Augusta, Georgia, for his brain tumor clinical trial that gave you a few more years with a high quality of life. After all, we do want a cure, but after all, we sure want better treatments on the way to the cure. But then, as Dr. Johnson had gently told us from the very beginning, the treatment stopped working, and it just broke my heart. I knew when we had our last Zoom call where things stood. I guess that now that you're in heaven, you probably already know this, and I already confessed it to your mom, but I recorded your voice just so I would have it. I recorded what you said when I asked you to speak from your heart and tell me what would you tell the ladies at the White House and in Congress if you had the opportunity. The first thing you said in true Caroline fashion was, well, I'd have to think about that. And I said, not really, just speak from your heart. And this is what you said. You should make clinical trials more available to kids and not take so much time. Truth, girl, truth. I couldn't agree more. There were trials we were waiting to open that you would have qualified for, but we knew they wouldn't open in time. You went on to tell me how you were going to be the manager for the wrestling team at your high school. And I laughed because sometimes doing all this advocacy work is like being on a wrestling match. You score a few points, you don't get some points, but in the end, through hard work and perseverance, your bill is passed into law, the funding you need is secured, or the need to change a law is done. I 100% agree with you that clinical trials need to be more available for kids and not taking so much time to open. That is a great advocacy goal. As a matter of fact, you know that Rally has already started working on that. We are laying the groundwork and fact-finding, looking for low-hanging fruit, and there is so much low-hanging fruit. I just wish, with all my heart, that you were here with me to go to the Hill. Well, actually, you will be. You are my petite heavenly advocacy angel. You and all the kids who have fought so hard and died are the main ingredient to my advocacy secret sauce. Together, Caroline, we will rally on. Miss you, girl, and love you. Y'all, it is the kids, and it is why we do it. That is the main ingredient to your secret sauce. All of you have a voice, and your voice matters. And together we will make a difference. And now I'm excited to turn it back over to Lisa, who we have an incredible panel for you. But y'all, you can do it. You can make a difference.
Isn't she incredible? I love working with Dean. She inspires me. Another person that inspired me the last 4 years after Jace was diagnosed is Zoe Jane Betker. And Zoe passed away last night, and that is heavy on many of our hearts. But after an almost 6-year battle with DIPG, she also gave us so much hope in her fight and always reminded us to dance in the rain. So I echo your words, Dean. I know that we can't do this in our small group. We have to keep making that circle bigger. That's something my son would remind me of often, and our circle became much bigger when we met one of my new dear friends, Ashwini Davison. Dr. Davison is a healthcare executive advisor at the academic medicine vertical of Amazon Web Services. And as a board-certified physician in internal medicine and a subspecialty certification in clinical informatics, she's passionate about bridging the data chasm between clinical care and scientific discovery. Let me tell you what I really know about my friend, Dr. Davison. You say, I don't take no for an answer. She could write the book. And we need her, and she's in our camp, so please give her a round of applause. That's what we know about our favorite sauces, right? It takes lots of ingredients, but I hope you heard one thing, and that is how much weaved itself together in a year, but only because the foundations were already there. A strong marketing company, a very strong CBTN who's worked decades, X-Cures who's been in the DIPG space 5 years, on and on and on. And this is just one example. We have lots of pediatric brain cancers, don't we? This is just one example, but it's something that maybe in a couple of years we'll have best practices from, and we just continue to expand and expand. So we've asked our perfect moderator, Caitlin Barrett, PhD at Milken Institute, who I have to tell you is one of my favorite people on earth. She moderated last year's panel, if you were here, and so many great things came out of it. Changes in trials, sharing of data, a very large gift to a wonderful children's hospital. All of these conversations that Caitlin helped create. And so I was so honored when she said that she would lead this panel. Caitlin, before you introduce your panelists, I want you to talk about what you do, because that's the most important thing that I can do in handing it to you, is give you the mic to talk about the way you're working at Milken.
This was fully unexpected. Thank you, Lisa. We have very limited time. We have some of our group going over to the White House after this, so I will be very brief. I work with philanthropists that are interested in moving into different medical research spaces, and I help them develop the strategies to do so in a very scientifically meaningful way and fill gaps in funding as well as in research. So that being said, I'd like to invite the panel up here now. Some absolutely incredible people, and I'm going to sit with them because I prefer that this be a conversation, and then we can get started. I'm going to make AV really struggle today. Okay. I have lots of notes here, and thanks to Dean and Ashwini, I get to ignore all of them. I just want to start with a quote from Melinda Gates. "The world is full of what seem to be intractable problems. Often we let that paralyze us. Instead, let it spur you into action." And you've seen a lot of the results of action up there. But what I want to do today with these absolutely incredible panelists is look at how they've seen that action working in their positions. And in order to save a little time, I'm going to allow them to tell you a little bit about themselves, but in the context of my first question, which will go to all of them. And we are actually going to start here with Krista Kerkorian at Day One Biopharmaceuticals. Krista, can you tell us how advocacy has most impacted your work? Give us a case study if you'd like. And before that, tell us a little bit about what you do and how you interact with advocates, because we've heard a lot about Hill advocacy, but pharmaceutical companies need to be talking to you as well. So I want to inspire you to think about all the different ways that you can interact with the different stakeholders within this environment and make sure your voice is heard and make sure that progress is made to benefit your family.
Thanks, Caitlin. Hi, everybody. My role as an industry patient advocate is different from a lot of what we've talked about this week. So within the pharmaceutical industry, patient advocacy can include lobbying on Capitol Hill and legislative policy, but where at my company at Day One Biopharmaceuticals, where we are focused is on being the conduit between the patient community, the nonprofit organizations that represent patients and families, and our company. So in the work that I and my colleagues do, our goals are to learn from all of you, learn from your experiences, your insights, your needs, your preferences, and bring your voices into the company so that we make more informed, better decisions as we work to develop new medicines. We also work to bring that our insights, our experience out to all of you so that you're more informed and understand where we're putting our efforts. There are actually two examples that I'd like to raise as where I have seen advocacy have a tremendous impact on the work that I do. And the first one, just very quickly, is that I would not be sitting here today if not for the small group of families who more than a dozen years ago provided the seed funding for research into new medicines for pediatric low-grade glioma that ultimately led to the discovery of the drug that Day One is now investigating in clinical trials. So certainly for the children and families who participated in our clinical trials, and for any children who may receive this potential new medicine in the future, obviously huge impact. The other example that I wanted to raise that I think is one very more tangible, immediate way that I've seen advocates have impact on drug development is with another company that I'd worked for before Day One, where we had the opportunity to share a clinical trial design with a group of advocates, a nonprofit organization, and it was in a rare adult cancer. And I would say that going into this meeting, we felt very confident that we had a well-designed, scientifically sound, really like almost fully baked clinical trial. We'd spoken with the FDA, we were in great position, and we're really proud of our work. But in that meeting, there was one point that came up where literally I saw an advocate stand up in a room with about 20 people. She wanted to be seen and heard, and she said, absolutely not. You have to change that. There is no way that anyone will enroll in your study if you don't change this one component of your clinical trial. And we heard it. We heard her, and we talked about it a little bit during that meeting, but we did go back to the FDA. We did redesign the trial. Ultimately, that study enrolled more quickly than we could have ever imagined. And years later, that drug is now approved. But I just wanted to say your voices, what you think, what you know about your experience, drug companies do need and want to hear about it. So I'll leave it at that.
Thank you so much, Krista. I think that what I'd like to move on actually to the other end of the table. Told you I'm giving everyone a workout. I'd like to talk to Dr. Gregory Riemann. He is the scientific director of the Childhood Cancer Data Initiative at the National Cancer Institute. You heard a little bit about several spaces where he's actually been contributing his expertise. And Greg, I love these solid examples, but when I talked to you, you said, oh, it's not a question of what the secret sauce is. It is the secret sauce, and I want to share what that looks like. So Greg, I would love to hear your example and maybe one of the really key things that you needed or that was helpful for an advocate as they were working with you.
That's a tough one, but I guess I have the benefit, or maybe the lack of benefit, of probably being the oldest person on this panel, and having been involved in pediatric cancer for my entire career, which now spans more than 40 years. I've really seen what has happened with legislative change, and legislative change that has been totally made possible because of advocacy. I, as a physician and clinician, long before I became the founding chair of the Children's Oncology Group, was always struck by how families could turn an unspeakable tragedy into something so forceful and so positive. And it was truly inspirational and transformative for me and my career. And just just being able to support that in whatever way possible, I think was really important. I actually did spend time with Congressman, with Mike DeWine, as they were introducing the pediatric exclusivity provisions, which actually preceded the Best Pharmaceuticals for Children Act, which provided an incentive for drug companies to do pediatric studies of drugs. And also there was a companion piece of legislation called the Pediatric Research Equity Act, which the BPCA was sort of the carrot. It provided an incentive, whereas the Pediatric Research Equity Act was the stick, which was a requirement, which unfortunately, as part of the pediatric rule, was turned down, but then was later introduced and passed. But there was a huge, I think, unintended mistake, which I spent years trying to point out, and that companies had to develop drugs for children that were approved for indications in adults if it was the same indication. So cancer drugs that were being approved for breast cancer, colon cancer, prostate cancer, weren't being developed in children because children don't get those diseases. They get very different kinds of cancers. So for years, for more than 20 years to be exact, PREA has really benefited drug development for children with diseases other than cancer. So why were children with cancer excluded? And with the advent of precision therapy and precision oncology, it became obvious that some of the molecular or genomic drivers of cancers were shared by pediatric cancers, totally different kinds of cancers than those that occur in adults. So this really did provide a scientific evidence-based opportunity to really lobby for changes to that legislation and make it equitable for children with cancer, and that was the Race for Children Act. It was a hard sell. It was a very hard sell to industry, who really was not interested in having to do anything more than they were already doing in the pediatric space, and clearly in the pediatric cancer space, a rare disease. What was going to be the return on investment? We don't want to touch that, and we don't want to spend the time and effort. It was also a little bit of a pushback with Congress because they didn't want to give a special consideration for cancer, but why not? It's a leading cause of death from disease in children, so why not give it special consideration? And there was even some pushback from people in the pediatric oncology space because they didn't really know how this was going to play out and how we were going to be able to do this. So it really took families. It took families with children delivering their stories to actually make it work. And as Dean said earlier, it wasn't the meetings that they had with representatives in Congress. I mean, that was just, get a signature and take a picture. It was the meetings with staffers. And to hear those children tell those stories was just unbelievable. And for 20 years, I went every year to Congress when I was chair of COG and vice chair of the Children's Cancer Group before that. People wouldn't even look at you as you're giving a presentation. But once a child started talking, once a parent started talking, you could hear a pin drop. And that is the essential ingredient of the secret sauce. You have the stories to tell. You tell them beautifully. Unfortunately, you have to tell them. But they're so important. And I just am amazed that you're able to do it. And whatever we can do at the Cancer Institute to support those efforts, we're here to help you. So, thanks.
Thank you so much, Greg. And actually, a perfect segue to the next person that I'd like to speak with. And John, I'd love to know how advocacy looks from your position as a legislative director, and what it is, in your experience, that's most valuable to lawmakers that are actively evaluating what must be competing priorities. What does that look like, and what makes it successful?
Sure, thank you. Hi, everybody. John Lee, I'm Legislative Director for Congresswoman Nikki Budzinski. She's from Central Southwest Illinois, but prior to coming to Congress, I had the honor of working with the National Brain Tumor Society and the Society for Neuro-Oncology for about 7 years with my good friend Danielle Leach, working on brain tumor and childhood cancer advocacy. So I saw it from the outside first, and then made the decision to go into government to try to firsthand get the experience of seeing what it looks like on the inside from those offices. And to the question sort of how, what gets the attention of an office and how those messages can really resonate. I think the example that we talked about and that I thought of this week is you probably are all reading about the UAW strike, and I think it's fair to talk about this because I didn't see any auto companies on the sponsor list, but we happen to represent one of those plants just outside of our district near St. Louis, and we have auto lobbyists come to our office frequently. We even have the representatives for the unions come and talk to us about what's happening on the ground. But what's actually most impactful is when you hear directly from those workers who are on the lines, who are now having to survive off $500 a week out of the strike fund to support their families. And those stories resonate far more with my boss and my team than hearing the corporate person coming to the office, right? And I think that this week especially, we saw it in real time. My boss made the decision on the spot after hearing directly from strikers to then change her schedule to go directly to the picket line in the district, right? And I'm not so certain that me trying to convince her to do that, right, would have been the same outcome versus directly hearing from constituents. And they told a really powerful story about how their dad and grandfather all worked at the plant, were able to create middle-class lives with vacations, putting kids through college, and nowadays this same wage doesn't provide for any of that, right? And fundamentally, that's not fair. And that's the message that you all are telling when you come to Congress, right? That you ultimately are dealing with probably the most unfair situation that you could probably possibly have on your plates, right? And unfortunately, right, it is now your job to get this select group of 435 members and 100 senators to come and listen to that. And there's sort of tips and tricks that I'll go into later, I think a little bit later in the panel, but just knowing that your personal story can change schedules, it can change votes, it can change how an office prioritizes. It is worth your time, your effort, your resources to be here. And I thank you all for doing that because I know it's not easy and it does really result in change. So thank you.
Thank you so much, John. So, Dr. Catherine Young, you're Assistant Director of Cancer Moonshot and Global Engagement at the White House. But I'm going to switch this question up a little bit for you because prior to this, you were at the Shepherd Foundation, which did advocacy in rare cancer, and I would love to know how that experience has influenced what you're doing now and how you interact with advocates.
Thank you so much, Caitlin. It has had a profound experience on my current position. So the way, kind of just taking a step back to describe how I got to this position, I worked at the Biden Cancer Initiative prior, which was then former Vice President Biden's nonprofit that continued the first Cancer Moonshot in between administrations. And then, of course, he decided to run for presidency, and we all had to get jobs. And so I was very fortunate to end up as the executive director of a rare cancer advocacy organization called the Shepherd Foundation, where I spent the next 2 years really enmeshed in the rare cancer community. Following that job, very fortunate that my now boss was elected, and we were then brought back into the White House to continue the Cancer Moonshot work. But I think that 2-year period of working at an advocacy organization fundamentally changed how I think about childhood and rare cancers. It is something that will affect you in everything that you do. And so I do believe this is experience that has been very helpful because I wake up every day and one of the first questions I ask myself is how do we accelerate solutions for our children quicker because they deserve better. And I will say on the flip side of that is that I am now continuously frustrated because I now live in the system that I was working, trying to tell stories to and influence on the other side, and now recognize how difficult it is, even being in this system, to make significant change happen very quickly. And so I think, really coming to that balance of bringing both worlds together has been a very fortunate thing for me to experience, but also very grateful for it too. I think I have been so fortunate to get to know so many of you in this room, and just want to share that your experiences, your stories, the work that you do have such an enormous impact in the work that we're trying to execute on at the White House level. So thank you so much for everything that you're doing because it truly does make a difference.
And I think that the theme that we can see arising right now is this idea of stories and how important these stories are. And I am very fortunate to have on this panel Randy Tan, because he's going to help us understand what implementation looks like, what these stories can do, and how he thinks about them. So Randy is the Director of Global Public and Social Impact at Salon. It's so wonderful that Lisa has met you and your team, because there's so much that you can teach us about what it looks like to take those stories and move them into action. And I'd love to hear, as you've heard all of these panelists speak, what your thoughts are in terms of how we communicate these stories and what the strategy could be as we want to move advocacy forward.
Thank you, Caitlin. A lot of the most pressing challenges our society faces are not just an issue or a challenge for government or nonprofits or academic medical centers to solve. So it's an absolute pleasure for me to be working at a company like Salon that works across these organizations to achieve certain missions. All right. So Caitlin, I love your question at the beginning around the case study. And the idea of one of the secret sauces is how do we implement passion into mind, into results, right? And so I think we spend a lot of time in passionate areas, passionate conversations, but I'm always driving towards, okay, what is the next step? How do we implement that action, and how do we achieve outcomes? And so a personal story, another significant challenge facing all of us, facing our children, our communities, is gun violence, gun safety. 2 years ago, there was a significant mass shooting in Sacramento, where I grew up. In my neighborhood, the shooting happened. So I asked myself, I can get angry about it, I can post on social media about it, but what more can I do to make an impact? What more can my company do, of 13,000 people, do about this problem? And so we identified one of the leading gun violence reduction organizations, a nonprofit in New York called Everytown for Gun Safety. And I asked myself, what can we do to enable them to better achieve their mission? So with our friends at AWS, using artificial intelligence, we have now enabled them to get better at refining what their campaign messages are, refining what their strategies are to reduce gun violence in this country. And I'm really excited to report out what the results of that will be in the coming months and years. And so the point of that story is all of us has significant passion towards solving problems. It is identifying who are those stakeholders that are gonna really help you move the needle and really make outcome happen. So I am so excited to work with this group, with all these panelists, and be involved in this community. Thank you, Caitlin.
Thank you so much. So what I didn't tell Randy when I spoke with him and we talked about these case studies in preparation for this was that I get a text message from Everytown pretty frequently, and they're doing a really good job because it's always right when I need to see those messages. So if that's how this kind of activity can work in this space, that's really meaningful, and we need to be pushing that forward. So we've heard some case studies and learned about how each of our panelists interact with advocates, and now I'd like to explore some different approaches and tools. And Greg, I'd like to start with you because I was in the session on omics, and through a turn of events that Adam says he didn't plan, it turned to advocacy. And you can see it everywhere, this need for advocacy. And one of the things that Greg mentioned to me when I was speaking with him was that there needs to be a champion. And I can see it in every space. And I can see the Adam Resnicks, and I can see the Greg Riemans, the people that are working in these spaces and have this knowledge and can help tell you, point you in the right direction, just help you tell that story. So, Greg, I'd love to hear from you what it looks like to find a champion. How do you find that champion?
Well, I think there are different kinds of champions. I think there are champions that are outside government agencies, and I think they may be a little bit easier to find to some extent because the issues that need to be addressed are very obvious to them as they are to patients and families, because some of those champions deal with those same issues every single day from the other side of the desk, perhaps. The other kind of champion are internal champions, so people who actually work within the agency that might be in a position to make a decision. And that gets a little bit tricky because officials in the executive branch aren't supposed to even comment on pending legislation and certainly not participate in writing legislation. But there are opportunities to provide technical assistance once pieces of legislation are in fact in play, are introduced. Legislative staffers and committee staffers actually call upon regulatory agencies to ask about the impact, either positive or negative, of a potential piece of legislation. And there are really opportunities there, I think, to actually turn the needle, if you will, and change minds of our legislators. So I think identifying people who are interested, willing to partner as internal champions, I think is a strategy that really needs to be employed. And I think this community doesn't really need to know how to select champions outside of government agencies because they work with them on a daily basis and have very intimate relationships with physicians, clinicians, clinical investigators, laboratory researchers, nurses, social workers, who all provide care, provide opportunities and support research activities, but more importantly, support families, and can certainly support families in their lobbying efforts.
And John, you hinted already at this next topic of conversation, and I would love to talk to you or hear from you a little bit about what raising my hand before I talked to you was a black box, and what does it look like when an advocate approaches you? What is a great approach?
Yeah, so I think, and to the previous point too on sort of champion building, this is my second boss on Capitol Hill, and she's new, she's a freshman, and something that I didn't realize is these members are also looking for their individual lanes of how they're going to be impacting public policy as well. And part of this is kind of a matching process of finding who your audience is going to be that really wants to go to bat for you. My boss in particular, her nephew has Down syndrome, participates in Special Olympics, so that was one of the first issues she wanted to work on, right? Because she has that family connection. She comes from a family of veterans, so join the Veterans Committee. I think from your meetings on Capitol Hill, what you can find out pretty easily through these conversations is, A, does the member have some type of tie to childhood cancer, but also as Dean hinted to in terms of the neck of the member, and I don't think I'd describe myself that way to her directly, but is there a staff desire to focus on these issues, right? I worked with NBTS for 6 years. I want to help you all, right? Like or you may have a family connection too, and that's really how you start those more formidable relationships where you can then count on those offices to really reply to your emails, sign on to the letters that you need them to, be at the events and speak at the events to help raise awareness. And I think one of the best examples of this that comes to mind is some of you may have been tracking, and this goes back 2 or 3 years, but the price of lomustine, which was standard care for GBM. It was one sole provider who was jacking up the price upwards of 2,000%. And we were collecting at the time stories of folks who were directly impacted by this. There was just one company in Florida that decided to take the drug off Medicare and Medicaid for further profit seeking. And because that champion building was done ahead of time, we knew which offices we could go to that would mobilize quickly. And I think that's really key in the sense of when something happens overnight, right, you know that an authorization is expiring that Dean talked about in one of those bills, that you're not starting from scratch with an office. You've really had these conversations. They may know you, your family's story, what community you come from. You have other folks from your community who may have relationships with the boss too. And that's where I've seen the most successful outcomes of this. And in the case of lomustine, we had 8 members who called out the company publicly, and it took a year or so, but the company did return the drug back to Medicare and Medicaid. So that's to say, champion building is important, but use all your resources. It's not just the member, it's staff. And once you have that information, spread that, hold on to it, so you can keep a good database too.
Such a great example, John. I really, really appreciate it. And now, what was it, Dean? The 100,000-foot view? We're going to go up a little bit, and I'd like to hear from you, Catherine, about what it's like implementing the Biden Cancer Moonshot. What are some of your challenges, and how are advocates stepping in to help you?
Yeah, thank you. Well, to piggyback on the piggyback of champions, I will say that we are so incredibly fortunate to have a champion at the highest leadership level here in the United States, and that is the President and First Lady. And why they are your champion is because they share many of your lived experience of losing a child. And that is incredibly powerful. It moved them so much that the president has actually stated before that one of the reasons why he ran for presidency was because of the Cancer Moonshot. This is not something that he just put on his political agenda to get votes. He actually authentically wants the Cancer Moonshot and the work that is created and the impact that is made from these policies and these resources and these tools that are being developed by the federal government and our partners in the community to be his legacy. And you are a huge part of that. We interact with advocates all the time. We want to hear your stories. In fact, the pillars of the Cancer Moonshot were really formulated around conversations and forums where we brought patients and advocates together to find out exactly what it was they wanted to see change happen in. And that is how these 5 pillars that we have that we execute on were formulated. And we also have a boss that comes to us on a regular basis and wants to get updates. So we are moving as fast as we possibly can. We have activated an all-of-government approach to this. The president has convened for the first time a cancer cabinet, which brings together cabinet-level secretaries to the table to discuss and strategize on how each agency is working towards this mission. This is a once-in-a-lifetime opportunity where we can all come together, the federal government, the private sector, the advocates, the patients, to really see the biggest impact that I think we will see in years to come. And you play an incredibly important role in that. And one last thing I'll just mention is that we want to hear from you. I know sometimes it seems like, the White House might be this black box where we don't want to communicate with the communities. We do, we absolutely do. So please never feel that you cannot reach out to us to have a conversation, because we are here, we are open to hear your ideas and your thoughts, and we really want to work hand in hand with you to make sure that the solutions we are putting forward are the solutions that work for this community and the solutions that you really want to see change.
And I'm really happy to stay on this theme of champions, since everyone has brought it back. And Krista, you are essentially a champion within Day One. I mean, you and your team are advocates for advocates. And I would love to know how advocates are supporting your work and what it looks like, what the characteristics are of an advocate that comes to you.
Sure. I would say that, I've been jotting down notes as others have been speaking on the panel about partnership, champions, relationships, collaboration, and I would say those are the characteristics of how we do advocacy with all of you. The partnership component is so important, and it's also something that I know for me, when I joined Day One and I first started kind of hitting the ground running and saying, okay, I'm going to go partner with pediatric cancer advocates and pediatric brain tumor cancer advocates. But I didn't really know what you all were looking for in an industry partner. I had some ideas about what I thought we wanted to do, but I think to be a strong partner with industry, with government, with academia, it's about having conversations and understanding what your shared objectives are, understanding how you want to communicate, how you want to work together. And in my, at least the first year that I was at Day One, I did so much more of asking questions, listening, than really talking, because I needed to know, what does this community need from pharma? And I learned first and foremost, you want us to focus on pediatric cancer drug development and not give up, and that was loud and clear. In addition to that, you want us to communicate, whether it's one-on-one, in groups, and the relationships we build transparently, openly, have an actual relationship so that you can pick up the phone and call me, call others within Day One, and it's not, how do I get to the person who I need to talk to? Participating, showing up at events like this, not just cutting a check and saying we're going to sponsor this and not being involved, but across the board, sharing what we do best, which is drug development. So what we know, what industry knows about drug development, so that when you're funding research, when you're donating to research, that you think, okay, this is what pharma looks for when they want to develop a new drug. So having those insights that, around drug development. And then finally, we want to lift all boats, and you want us to do that. So be inclusive, bring more groups, bring more industry into the mix. And I would say those components are really what advocacy looks like, both for us and I hope for many of you, and how you work with us.
Yeah. And Krista, I really appreciate your initial strategy that you shared with us. And we have a strategy person on this panel. And so I would love to hear from you, Randy. How do you build a strategy? An advocacy strategy. Just build us one right now at the table, please. Thank you.
We can do another day on that. Caitlin, all the elements we all have been talking about around partnership and collaboration, champions, are all keys to the strategy. Right, and so I love what John was saying around, you really need to understand whose mind you are looking to change and what motivates that person or that entity, right? And so not only that, it's also very important to know who your partners are gonna be toward that end. So my mom and dad, love them to death. They're in their 80s, stubborn as heck, so stubborn. They raised the 5 boys, and I know, based on the experience and what they think of each one of my brothers, depending on the topic, I approach them with a different combination of brothers, right? And so that is critical with all of what we are doing to really understand what's changing, what's gonna move the needle with who we are looking to move the needle with, and what partners we need to bring to the table based on their different experiences. So I think a big part of the strategy is who are your stakeholders that you're gonna go to bat with, right, to move that needle. Because I tell my colleagues at Salon, I tell all of my customers, life is too short to spend time only on strategy. We need to make action, we need to implement, we need to have data-driven results. And so that is the key to any strategy, is that implementation roadmap. You know, what are gonna be the metrics of success?
A roadmap is a really nice strategy. Thank you, Randy. So as we close out this session, I think what I'll summarize is telling your story is so very powerful and so very important. And Dean started with a story that I think moved us all. And we've moved through other stories. Find your champion, collaborate. And I love the data thing. I'm a total data person. So come with the same language, come with support for what you're looking for. And if you have a champion that has that knowledge, definitely utilize them. Dean started with some gracious thanks, and I want to also do so. I want to thank the organizers of this summit for their very thoughtful inclusion of this particular topic in the luncheon, which is such an important part of the Brainstorm Summit. And thank each of the panelists for sharing their time and their perspectives with us today. And of course, thank Lisa and all of the people that plan this meeting. It is not easy, but it is a passionate and love-filled task that I know Lisa wants to do for a long time in the future. So just all of my thanks, and I hope that everyone enjoys the White House viewing or going to the White House, and very thankful for your time today. Oh, one more call, Lisa's challenge. Now you know how in the next year you can get involved. So let's do that. Thank you.
That's exactly right. What brought each of us to this room was a moment most of us don't want to relive. For me, it was with my 20-year-old hearing inoperable, terminal aggressive. And you either get bitter or you get better. Going through, many of us have, whether that's a life of survivorship filled with challenges and adjusted reality, or whether that's knowing your child on the other side. But what we have is that story. And we have a story we don't want anyone else to have to live through, am I right? If we can make a difference. Or maybe you're a doctor and you're just tired of knowing there has to be a treatment that works. If only we could get it to market. If only we could fund a trial. That's why we have power that we cannot avoid. We have the story. We have some amazing champions inside, outside of government, in industries. There's not one people here that I wouldn't call on the phone and say, I have a crazy idea, right? And you have them too. You have things, you know of gaps that I would never think of. You have experiences I've never had. During the last 2 days, we've talked about hospice and palliative care and the need for best standards. We've talked about needs to make trials more available, diagnostics more accessible. We've talked about laws that have to change. And so maybe as you listen to the panel or others, you were saying, okay, what do I do? What's the call to action, right? Maybe those that we need to influence are waiting for the same thing. What do I need to do at the FDA? What do I need to do at the NCI? What do I need to do at Cancer Moonshot? What do I need to do at a pediatric drug company to make it better for you? Do you see how that's a two-way conversation? Sometimes we assume everybody knows our side and they're just ignoring us, and that's why we can't get any answers. But maybe we have to meet halfway. Even though we've gone through the tough stuff, we somehow are getting through it. And if we want someone else never to have to, we have to do that one more step. We have to tell our story. We have to sign up. We have to show up. We have to work together. What would happen if we all shouted different words in this room? I wouldn't hear any of you, would I? But if we start to use some common language, the same 3 or 4 words over and over and over, I, as the receiver, start to say, there's a lot of people talking about that. We probably need to work on it. Even though my secret sauce has a little different ingredient than yours, and my family recipe feels a little different, at the base, we have the same formula. Here's what we can't do. We can't keep shouting our own name first. I've sort of cringed as I got to this point in Brainstorm Summit. I don't want to hear Lisa one more time. I really don't, because it's everybody in this room that we're fighting for. If I thought it was only my son's gone. But he fought for you and your kids, and you do the same, right? That's who you're fighting for now. So, I'm going to give you a call to action. I want you to find legislation or a gap or a foundation that is doing something to change the standard of care, the status quo, to break down those barriers. We can do what others sometimes can't. They have to stay employed at the academic institution. They have funders they have to please. They have political agendas that are far more than cancer. We don't have that restriction. We can tell our personal lived experience with a passion that someone else can receive. And we cannot do it without you. I say all the time, I've worked harder than I ever have in my life for free. But it's been my favorite job because we are going to see real change. Everything that we've talked about, a lot of what we've talked about in the last 2 days, has happened in 2 short years. And before that, folks like Chad Tuff, Lila B, and others, they were doing the same thing. But we have to work together. And we get tired. And we have to have your help. And if you're in this room, I feel like you care enough to do it. And so my call of action is to just show up with your special ingredient, and let's make the special sauce the most memorable sauce we ever can. Let's change history for pediatric brain cancer. Let's remember the day we were in this room and we said, yeah, sign me up, like Ashwini did, like XCures did, like CVTN did. Like, we have those champions, guys. We have to keep rallying around them. And I can't do it alone, and you can't do it alone. But together we will, and it starts today. How about that? All right. Well, on behalf of all your lovely children, so many that I know and miss with you and fight with you, and we're going to go over to the White House, some of us, and we hate to leave you, but we know that voice has to be there. And you guys get choices. You're going to have another session in between, and then you can watch the viewing of the White House from 2 to 3. You can participate in roundtables. There's events tonight, and if you're here in the morning, I'll see you at the breakfast. But if I don't, I just want you to know how much I personally appreciate you taking a chance and attending. I know it is at financial cost and cost of your time and cost of your emotional space. And I thank you for that. If you've been in a session and there's somebody that you're like, man, that resonated with me, don't leave without talking to them. Don't leave without saying, that really mattered to me when you said that. How can I help? Don't think your voice doesn't matter. If there's anything you can get out of the next 2 days, use your voice. Use your voice, use your voice, use your voice. And keep fighting for those kids that are too young to share theirs. All right, have a great day, guys.
Great. Thank you, everyone, for joining us this afternoon for the Innovative Trial Design session. It's really a pleasure to be here with everyone. Before we start some of our discussions, I wanted to introduce our panel, and we actually added a member just spontaneously. So maybe each of you can just go through it and introduce themselves and quickly sort of highlight in 1 or 2 sentences what your role is sort of in clinical trial designs for children with brain tumors.
So I'm Cassie Klein. I'm one of the pediatric neuro-oncologists at the Children's Hospital of Philadelphia, and then I'm also the director of clinical research there. And alongside Sabina Mueller, I'm the PNOC, or Pacific Pediatric Neuro-Oncology Consortium project co-leader.
My name is Sarah Merrill, and most importantly, I have a 6-year-old niece who is currently in the fight with DIPG, and I work and serve for an IRB at the University of Louisville.
I'm Elias Sayer. I'm a physician scientist and pediatric oncologist at the University of Florida.
I'm Tab Cooney, medical director for Day One Biopharmaceuticals.
Hi everyone, my name is Yevgen Timofeyev. I've been working in pharmaceutical industry a little bit short than 20 years. I'm a statistician and modeler currently at the Janssen Research and Development, Johnson & Johnson.
Hi, I'm Nicole Dresner. I'm the Deputy Director of the Division of Oncology 2 at the FDA, which is the division that handles pediatric and rare solid tumors and neuro-oncology.
And I'm Sabine Müller. I'm a pediatric neuro-oncology at UCSF, and also one of my main interests is really developing a new clinical early phase trials for children with brain tumors, really with a focus also for diffuse midline gliomas. So when we met before today and sort of brainstormed a little bit what the session is about, because obviously we need to have a lot of innovation about how we conduct clinical trials. And I think the challenging we face for pediatric brain tumor clinical trial research is obviously it's a very rare disease and it's a very heterogeneous group of tumors. And even if we call something now diffuse midline glioma or medulloblastoma, we have different subsets within these bigger categories, further sort of making our sample sizes smaller. So there's obviously a huge need for sort of international collaboration so that we can enroll effectively and in a timely manner and also learn rapidly to bring new therapies for these children in need. The other thing we are facing from when we think about clinical trial designs, and that's also from an industry point of view, is the pediatric brain tumors, they span, from an infant up to young adults, and a lot of our trials actually enroll also the young adult patient population up to 39 years of age. So just when you think about how we can design trials in terms of just the formulation of the medicine, but also how we can best assess side effects, it's obviously very different in an infant, in a 1 and a 2-year-old versus somebody who can really clearly communicate with you. So these are a lot of challenging we face. And then I think one of the biggest challenges we face is obviously the lack of funding and support from the government, but also from, and I don't want to put our industry partners on the spot, but there's really rarely a focus on the development of pediatric brain cancer in terms of therapy development from industry, although there are exceptions to the rules. But we are often faced that we see promising results in our pediatric trials, but then if a medication doesn't have an indication in an adult indication, then often industry is not further developing this, and then we don't have access to the medication anymore. And then obviously one of the things we are really aware of is obviously for diseases such as diffuse midline glioma, where we really haven't made much progress and sort of successful therapies, how can we fasten the transition from the bench to the bedside? Because sometimes it takes a lot of time and it's definitely too long when we have exciting results in the laboratory to really bring it to the patient. But I think what we also, and we've made great progress on this and also started to develop international trials. One of the other challenges we have, we enroll patients over several years in our trials, and we need to obviously await certain time frames so that we really understand the impact of therapies. But then translating this back off takes additional years. And so I think that feedback loop back to the bench is also very important and something I think we really need to pay attention to. So that is sort of all the challenges we face, I think, from an industry perspective, also from academia, when we think about developing clinical trials for children and young adults with brain tumors. And so I think we want to make this a really open discussion. So I first wanted to see if there's any questions or specific ask from the audience to the panel. And if there are none right now, please think about them, and then I will maybe start. And really, maybe that's going to everyone from industry, academia, but also to the FDA, really. How can we innovate around sort of some of the regulatory requirements we face? And that starts often that safety data needs to be present first in the adult population before we are allowed to move into pediatrics, bringing in multiple therapies within one trial, sort of this multimodal therapies. What we often hear from our families, it is so hard to have to make a decision. You are offered 2 or 3 different options, and you cannot really combine them. So how do we go about this? And what is sort of the current thinking? What are potential ways to overcome these challenges? So maybe I start at the very end, and then we can go through it.
So I think with respect to, I think you described the challenge well, and I think with respect to, the regulatory aspect of designing trials, and this is a theme that comes up every time we talk, but it is to meet with us early and often, because we can really help guide development in terms of ages. What generally happens for small molecules, ADCs, drugs that are regulated by CDER, is that drug development programs typically begin in adults and then trickle down to pediatrics. That's most frequently what we see. And so there is some data already that we can draw upon when designing or when helping to design pediatric studies. With respect to biologics and drugs that are regulated by CBER, there's often a requirement for them to be studied in adults first. And I think that generally, when the target of the vaccine or the biologic therapy is a target that can also benefit adult patients, the ask has been to study that therapy in adult patients first. But I do think that there's flexibility with that. First, in that the adult patient age range can extend down to adolescents, 16, 17. And second, that often those types of requirements to study the the therapy in older patients first can be built seamlessly into a single trial design, so that there isn't the need to develop 2 separate trials, which has a lot of, which obviously requires a lot of work on the sponsor's part to do that. So I think there's flexibility in all elements of the, there's flexibility in all elements of development. That's one thing I can cite for biologic therapies, which is that there can be seamless trial designs that begin in adult patients, and that age range can extend down to adolescent patients.
And Nicole, maybe some of us in the audience are not fully familiar. Can you maybe also highlight a little bit the complexity working with different programs at the FDA? And sometimes if you have a combination between a device versus a new agent, biologics, maybe just outline a little bit the process, how that, like, we either from academia or industry has to go about. I don't know if that's clear to everyone. Thank you.
So we all operate under the auspices of the Oncology Center of Excellence, which strives to bring together all of the groups within the FDA that work on cancer drug development. And so therapies that are vaccines or biologics are typically housed in CBER, whereas small molecules, immunotherapy such as anti-PD-1 drugs, antibody drug conjugates are all housed within CDER. But we do work together, very frequently. Generally, if the development is of a device and a drug, the initial development of a clinical trial will go to the center for which that drug would be housed. So if it was an immunotherapy, it would go to CDER, and we would consult our devices center, which is CDRH, as part of that. But since we all are part of the Oncology Center of Excellence, or the OCE, we internally will consult each other when we have meetings, so that we can have everybody at the table when we meet with the sponsor who are required or necessary for that drug development, whether it be a combination drug or a drug device program.
Thank you very much. Maybe to the next two panelists, sort of from an industry perspective, highlighting sort of some of the challenges that comes from our industry point of view when you think about pediatric cancer therapy development.
First of all, it's a great pleasure to be here. Thank you for the invite. And I probably one of the most nerdy person. I'm a statistician, and I confess the format of this summit is outstanding. It's great, but it's a little bit out of my comfort zone. So please, thank you for your understanding. I'm much more comfortable if we would kind of use some technical jargon, Greek letters, etc. Nevertheless, this is really, really a great experience, rewarding, educational. At the pharmaceutical, we always work with the slogan, patients are waiting. I want to leverage furthermore what Nicole already mentioned. It's actually been also very lucky to be involved in the recent past 2 years in the initiative that is run together by the FDA Oncology Center of Excellence, and together with American Statistical Association working group, biopharmaceutical. In particular, there was 2 forums. They were virtual over the Zoom. Nevertheless, I would say highly successful with regard to many aspects. The question asked and participation. It really a very large crowd of all parties involved, starting with patient advocacy, academician, industry, regulatory, of course, and actually regulatory across over the world. So there were 2 specific webinars, and I refer you for more technical details in kind of solution and things discussed there. And I pretty much in my answers maybe would leverage quite a few, but again, thank you for inclusion here. To me, the fact being here means it's recognized. It takes the whole village to design any trial. It takes much harder, much more challenging setting to design innovative and furthermore pediatric in oncology. So challenges are there, but opportunities are also recognized. If maybe my answer is now too long, I would be happy maybe to go to certain kind of tools and software, be specific what's on the table, what's in our arsenal when we design clinical trials. But the one and foremost, it's really collaboration of the team, clinical trials execution team, a lot of players, statistician, clinicals, functional, clinical pharmacologists, regulatory, you name it. It's not only on one side, sponsor, needless to say how much communication and kind of interaction happens with regulatory with ultimate purpose to deliver drug to the patients who are waiting.
Thank you. Tab, maybe?
Okay. I think, this might be a little difficult for me. For those that don't know, I was a practicing pediatric neuro-oncologist up until this past spring when I joined Day One. And so I'll try to speak on behalf of industry because I'm 5 months veteran. I think through most of my interactions as a prior academic, I think a lot of people who work in big pharma and biotech want to care about children with cancer, and they want to believe they are someone who cares about children with cancer. But at the end of the day, it's the financial systems that drive the behavior of these companies. And there's been a very pervasive narrative that caring about childhood cancer first or prioritizing childhood cancer is not financially sustainable. And so that's why me and everyone else in the Day One company is working so hard to change that paradigm. Can we build a mission that's pediatric cancer first, find those therapies that will improve their care, and then from those indications, look beyond to adults? Can we change the paradigm and look to the kids first? And the question is, right now, we don't yet know, but if we are successful, then others will see, and the paradigm will change. And so this company is about 4 years old, and we know we're doing well, and we have a few more years at least ahead of us, and we have a lot of work to go. But I think there's a lot of hope from everyone in our company, and hopefully in a decade, you'll be seeing a lot more companies like ours.
Thank you. Elias?
So I'm a sponsor investigator of first-in-human trials that have gone through the FDA at CBER. And there have been lots of challenges, at least with our negotiations with the FDA at CBER. To make a long story short, they, at least for our first generation immunotherapy vaccine, they demanded really an adult trial to take place first. And many of you in the audience who are supporting this work ask me all the time about when are you going to be in children. And it's what I knew many years ago when we first submitted this IND is not what I know today, because back then I really thought we'd be within 6 to 12 months of opening a childhood cancer trial. Now, I couldn't have imagined a COVID-19 pandemic, but there were other things that happened. The FDA, after the pandemic, because this is an mRNA vaccine, came back to us and put us on hold because they were nervous about some of the logistics around a childhood trial, a multi-institutional trial, and we're still trying to reconcile those federal holds. I think that the FDA has helped us out tremendously as well in the review and the guidance, but it has always felt to me like the minute you mention a child, it's a hard stop. It's like, oh, whoa, children, yeah, and you're basically frozen until you can completely satisfy them that this is safe and has a really good chance of helping them without really hurting them. And I've always found that somewhat ironic when I think of the field of oncology, which is we're hurting people all the time with standards of care, surgery, radiation, chemotherapy. And in some ways, if I were to think about the impact of novel therapeutic development for childhood cancer, I think I could say convincingly that it paved the entire field of oncology. It was curing childhood leukemia through combination chemotherapy that really paved the way for standards of care for adult cancers. And so and that wasn't that long ago. And so it's just stunning to me how in 50 years' time we went from, orphan disease investigation that paved the way for all oncology to hard stop, you're taking care of a child. I think we've made tremendous improvements. I think CDER is leading on this, honestly, in terms of the recognition of how important pediatric cancer is and getting indications approved into trial for children. I think there needs to be more streamlining of some of those guidelines within different aspects of the agency. So my hope would be that CBER follows some of CDER's guidelines. And I think that is important not only for getting trials approved more quickly, but it's the iterative process. So, for example, if we do get into children and treat them and show that this is safe, but want to combine it with X, Y, or Z, is it going to be another 5-10 year process, or is this something we can do relatively quickly with reasonable evidence that this is safe and potentially effective, of course? That would be my hope.
Thank you. So from your point, really taking sort of also this ethical consideration in play that often comes with our IOB reviews, and maybe outlining a little bit for the audience what that actually means.
Yes, absolutely. So
Thank you.
If you're affiliated with an academic institution, you would have your local IRB, which serves to protect the rights and welfare of human subjects, human participants. So any human that participates in research, the IRB is there to make sure that their rights are protected. And children, of course, are always a challenge because they're considered a vulnerable population, so they have even more restrictions and more requirements for any research in children in order for it to go through your IRB. Now, the IRB's biggest tool, I think, in research is the informed consent form, because that is the best way for these patients and patients' families to be informed of what they're agreeing to. And so I think as long as the families and the patients are being given options, and instead of opting out of something, I think it might be, I always prefer to see an option to opt in to a special procedure that might be new and innovative, and just make sure that they are fully informed of what they're agreeing to. And I would also encourage, from a regulatory standpoint, to have anyone designing a protocol to also get in touch with their local IRB during the design process. We're here at all points of design, but especially in the very beginning stages, it's so important to see what concerns you might have to get through when approaching an IRB.
Thank you. Cassie, any last thoughts?
I think that everyone has made phenomenal points on this panel already, and I think the one thing that I can say from an academic clinician too is, I think we take very seriously our role to educate as well. We are the ones seeing patients and families every day. We are the ones kind of, perhaps on the front line best understanding some of the dire needs for our patients. And so I think what we've heard along, a common theme is, this fear of children or pediatrics, and the regulatory concerns, and of course there being a vulnerable population. But I think we really serve in a role then that we need to take the rationale and the justification for why we want to do the things that we want to do, or push the envelope the way that we want to, or bring novel drugs or drug combinations, drug delivery systems to the patient, to parties like the FDA or regulatory groups that don't always have the insight or the experience with our patient populations that we do. And I think that when we are able to do that and partner with all of these groups, whether it be industry or regulatory, in many ways we are able to make that headway in ways that was not previously done. And I think, we have also gotten more facile at engaging all of these groups earlier on, and figuring out ways in which we can navigate or build our trials so that they seamlessly transition to, a combinatorial strategy if it first needs to be tested in a single agent, the older adolescents before it needs to be transitioned to the smaller or younger patients. And I think that working along a multidisciplinary team with your biostatisticians and your multidisciplinary clinical trialist, we can all come together and kind of create these novel clinical trial designs and subsequently back that with justification for why and how we want to do this. And I think that in and of itself, kind of coming in with that preparation and that lens of being or understanding that we're also going to need to perhaps show people that this is a area of great need. This is a patient population where right now there are no other options. And so this is why we feel justified to do this. And I think that's just another critical piece in our role in what we do.
Thank you. Are there any comments or questions from the audience?
I'm coming. Hi, this question is for the FDA representative. First of all, I'm a parent. I have a child with diffuse midline glioma, and I'm not sure why, but I'm just blown away that you would come down to this conference, and it shows that that you do care, and I really appreciate that. My big question is, as a parent with a child that has a tumor for a cancer that's primarily pediatric, that's uncurable and deadly, if we continue to put adults first in terms of these clinical trials, what would you say is the best strategy for researchers so that they can learn to treat, something as deadly and as horrible as what my son has, so that kids don't have to continue to go through this?
Thanks. And I didn't say it in my introduction, maybe I should have, but I'm a pediatric oncologist as well, as are all of my colleagues at the FDA who work on pediatric drug development. So we certainly recognize the dire need for therapies within pediatrics. I think, first of all, there is no blanket policy throughout CBER or CDER to require adult development first. we are flexible on a lot of different things, and really each case is unique, and we treat it as such. With respect to trials that, or advice that has required adult development first, again, I think that, first of all, adults can include adolescent patients, but second, for therapies that have no proven or known efficacy benefit, safety becomes a focus. And although we can certainly understand the need to sort of try anything, and probably what I would do myself, as a mom, when you're looking at it from a regulatory perspective, the potential toxicity for an unproven therapy is something that really does need to be considered, because a therapy that results in a fatal toxicity or even an irreversible toxicity that precludes your ability to enroll your child on another trial or to receive another therapy is something that should be taken seriously, and is. With that said, though, there is flexibility. There is no blanket policy. There is no policy. It really is a case-by-case basis. And in CDER, we have had development programs that have started in pediatrics, and resulted in successful pediatric programs. And that's where I work. But for CBER, I know that there is flexibility in terms of, where a trial needs to start.
Yeah, and I would say, I would agree. In the end, it comes back to, I think, this collaboration and education, right? I think it's educating on both sides. What is the viewpoint from the other party? But we did have, successful trials where it was first in human, and we agreed that first in human in children was acceptable, given what we knew about the therapy, given that we knew that specific therapy would only really be beneficial in children. So, I do think we see that collaboration, but it is, in the end, it's coming from a point of protection. Obviously, you as a parent, right? If the outcome is, as dismal as it is for diffuse midline glioma, unfortunately, your risk-benefit totally shifts in the other direction. So, I think we all understand this, and I think we try to be very mindful of it. But it's, I think, understanding the disease, and I think over the last years, we have done a lot, right, in educating each other around the disease. It started 10, 15 years ago with just the biopsy, right, which was not really acceptable, but we educated ourselves with it. But there's still a lot of work ahead of us, so I agree, but I think these collaborative Zoom meetings we sometimes now have on specific topics that are initiated by the FDA, discussing it from all perspectives, I think that is just really important. Is there another question?
Hi, I am Ronald's mom, and my son passed away 5 years ago from DIPG. And so basically, when we were here in the US, we were getting care here, but we were told that he only has a month left to live. And then we were, looking, researching, and then there was some experimental treatment going on in Mexico, and we took him there. And basically, they were using a multimodal approach, intraarterial chemotherapy, and they were using a lot of different drugs to attack the tumor. And when we were here, they said he just has a month left to live. And when we took him there, and there were a lot of other kids too, DIPG kids. And on an average, I would think that the kids got about a year. My son got 18 months more to live. And those are like a lifetime in a DIPG, case. So I was just wondering, why, it's been 5 years now, and why in the US it's taking so long to move the needle? Why are we not doing this kind of approach, because for parents, even if it's not a cure, even if it's chronic, or even if you get more time, that's all the kids or the parents would want. So why is the research or this is not moving fast enough? And, other countries are doing it, but why is it taking so long?
Anyone? I think that's it's a great comment, and it's a totally recognized challenge, I would say, right? I think some of the challenges we have when we think about this multimodal therapy, right, where we want to combine potential new drugs that have not been approved for anything else, so we need to get the approval in place, plus maybe some immunotherapy, virus therapy, etc. You need to get all these agreements in place from the different players. And I would say even just getting a device company working with a company where the medicine has not been approved for everything, so it's also investigational, has been really challenging. And that comes back sometimes, to the regulatory requirement, but it comes back, as Tab was saying previously, also to the intellectual property and who owns what and contracting and all of that. So in the end, I think the ideas are there that we would like to sequence different therapies, right? You maybe want to start with focus ultrasound and photodynamic therapy and then move to immunotherapy and then within one trial so that patients have an option to move on to different therapies and don't have to decide between options. Because our current trial design also often is you have at one point a chance to enroll in a trial, but then if you're not enrolling at that time point, you're not eligible in the future anymore. And so I think we are trying to change this now with allowing patients to entry at different time points, and I think we've definitely seen progress there. But I think that multimodal therapy that you're talking about is access to it and then agreement from the different companies if it's not just academically run.
And I'll just piggyback on that too and say that much of what has been talked about at this meeting is open sharing of data and information. And I think that we in this group all agree we want our clinical trial data shared as quickly and openly as possible. And if we are making headway, or alternatively, if something is futile, we are all very motivated to find that out as soon as we can and make sure that we're moving forward efficacious or effective therapies and abandoning ones that are not effective, or going back to the drawing board again and figuring out how do we regroup around this and move that ahead. And sometimes we do that very well across organizations and across groups, but you do face barriers, for instance, if there is not that open sharing of data. So if there is a technology or a drug or anything of the sort that is being utilized in an effective manner, we are all very open-minded to consider it and to think about it, and how do we implement that, and how do we get that into an appropriate setting so that it's reaching our patients. But I think the hurdles get put into place, for instance, when we don't know what is being utilized in other institutions or organizations. And sometimes we hear that something may or may not be effective, but that data can sometimes be hard to actually acquire. And so I think, again, advocating, there's no world in which any of us live in that we want to hold back something that we think is effective for your children. And so I will again just advocate that if there is an open sharing of data and helping us kind of translate and get that information out there, that's also a critical piece for how we effectively bring all this together.
And can I just add something to that also, that we have so many HIPAA protections in this country, and that limits our data access. But I can tell you from being a family member who we're going through the fight right now, we would be willing to share everything. I mean, my sister, who is Marguerite's mother, she said, I will put it on a billboard. I will share her data with everyone. And so I think that's something that we all need to recognize, is that we're at the same time that we're trying to protect patient privacy, we're in a race against time. Mm-hmm. And so we're, that's something that I feel like this community is not as concerned with,
Yeah, no, I do think that's a very important point, and we hear this over and over again, that families, especially, what we heard today here, right, are very willing to share their data, but then we are bound to certain regulations, right, and if you break them, then you can close your trial immediately, right, and so I think these are the challenges. On the other hand, I think we have to recognize where these regulations come from, right, and I think we just need to build systems, something what we heard also, right, where maybe people can go directly when the consent is given into the EHR and pull the data and share it openly. Because obviously in the adult space, that sharing of data is quite differently, right, and maybe has a very different impact. So, but it's a good point.
I feel like while we're designing protocols and consent forms, we're seeing this more and more of more data sharing access in the consent form. And I know that as long as you're allowing it, consenting it, then you can be more free to use it and share it.
Any other comments from regulatory or industry perspective really on that topic, which I think is such an important topic, how we can be more agile around this multimodal therapy that has happened in individual clinics, I would say, right? It really hasn't happened in a larger international regulated trial, right? I mean, if you agree with me on that, I think that goes under sort of individual practices has been doing this, where patients have to pay their way into this, and then the data is also not really made available and published. So I mean, I think that is the other limitations we have. I mean, we had Mexico, we have Germany. I mean, there's multiple of these private clinics, which I think offer something very appealing to families. And I wish sometimes we could just do the same here under the regulations, where we can then really share the data and understand who are the patients who benefit and who don't. But any thoughts from any of you around how we can really implement sort of moving a patient within a trial along and having access to multiple different therapy modalities?
If I may, I couldn't resist. You mentioned about strategy accelerating drug development, and you used the word agile. This is actually the acronym for the master protocol. For those who are not familiar, it's a platform that runs focusing on the disease area itself, and then different candidate experimental treatment runs simultaneously in a multi-arm fashion, sharing the same control arm. So an acronym for this is exactly agile. I know it's an adult late tumor. I wonder what this panel think. It's ongoing. I don't think we are ready to make comment about the success, but nevertheless, the idea could be very appealing and kind of, at least theoretically, allows to speed up, to accelerate development when not every single study, not every single protocol has to have their own control, their own experimental regimens, when we have kind of the airport infrastructure, so-called, built to process multiple candidates in the same manner. That might be appealing.
Yeah, and I would say we're starting to see these platform trials now also in pediatrics. We have one through PNOC. There are other platform trials where we're really trying to have the same endpoints. Patients can enter and really reiterating around this and learn quickly. So I fully agree that this is definitely where we see the field going, right? These platform trials where under the same umbrella we can test different combination therapies and then more quickly reiterate around that, given that the protocol and the infrastructure is already in place. I think the other venue we heard this morning, also from Ashley Margol, is that we develop this synthetic control arms where we have the control set and then we can quickly reiterate around this, but that is not trivial to build these control sets that are really, because in the end, we need to do trials with the goal in mind to have potentially a therapy approved, right? So that it's really accessible to everyone and not just to patients who have access to academic centers who offer this as part of the trial. And so we always need to keep in mind what are the regulatory requirements in terms of the data we generate that it could potentially lead, right, to an approval, which would be obviously that's the goal, because otherwise we are doing phase 1, phase 2 trials, but in the end it's not accessible to other patients. So I think we start seeing this in pediatrics for sure. I do think that's a great way to be a little bit more agile and integrated. I think one of the limitations we are seeing right now, like I mentioned, is just this feedback loop. It's just too slow right now, and that's an infrastructure and support problem. We just need more funding, basically, to get this quicker back to the bench scientists or to the clinicians with results so that we can more reiterate around this. But maybe leaving that topic a little bit, I mean, question? Yeah.
Hello, thank you everyone for being here. This question I think is probably more for FDA, but anybody could chime in for sure. So I think what I've noticed, at least me as a parent, when my son lost his battle, and advocates, and even talking and listening to a lot of clinicians here and researchers, there's a big frustration when it comes to regulatory requirements and kind of just the roadblocks that we're facing. And then I hear people talk about, maybe information sharing is another, roadblock for us. So it seems to be that we have just a lot of roadblocks here with making things available to help people, and then roadblocks of sharing information, but everybody wants to do this. Everybody, and I believe for FDA, if you have a pediatric neuro-oncologist that you're working with that are staffing the department, surely somebody has got to be thinking to themselves, something here is broken, it doesn't make sense infrastructurally for us to be able to move forward. If everybody's here saying we've got these problems, I guess my question is why, what's stopping us from fixing that problem?
Well, I think with respect to data sharing and constructing, databases, that's sort of beyond the FDA purview, and perhaps some of my colleagues, could address that. I do think there are large initiatives ongoing to develop databases that are fit for purpose and could serve as a type of external control or a hybrid control arm. With respect to the process within the FDA, we work within our regulations, and our regulations are that in order to approve a drug, it needs to be safe and effective. And effectiveness needs to be demonstrated through adequate and well-controlled trials. I think we're seeing a lot of flexibility within the adequate and well-controlled guidance, whereas, historically and in other settings from oncology, the requirement for demonstrating effectiveness has been two large randomized controlled trials, and that's clearly doesn't work for oncology and certainly not for pediatric oncology. And so, we have considered one trial and even one trial with a control arm that may be an external control or would be maybe a hybrid control, or includes a very small number of patients for single arm data as trials that could potentially support an approval. But and we put out guidance on that. And so I do think that we understand and recognize the need for regulatory flexibility for diseases for which there is a substantial unmet need, and we work within that. We work within that all the time. We have meetings with sponsors all the time, applying those principles. So, I think we hear you, and that's something that is forefront on our minds when we are evaluating clinical trials, knowing that the end goal is for registration of a drug, which in and of itself is a success, because besides the fact that it will be available to patients, it also raises the standard it also raises the standard for all of the clinical trials going forward.
I'll speak a little bit to the data sharing piece. So I'm not sure who attended the omics talk this morning, but I think, the challenge there is in many ways kind of bringing together the nonprofit and for-profit sectors in some ways, because we have academic teams, institutions, clinical trial consortium, that are trying to share their data, that want to be able to share their data, that want to be able to integrate this data. And there's a lot of private sectors that have been able to successfully do this. And I think someone spoke about LinkedIn, for instance. And but the challenge for us is similar to what we've faced with industry sometimes, is that who's going to pay for this? And so we are mission-driven, intrinsically mission-driven organizations. And we are, we feel that what we're doing, the patients that we're fighting for, should speak for itself. But at the end of the day, it's very challenging to bring together the other experts that have knowledge that we don't have in terms of how we build these systems, how we integrate them, how we put our data up here in de-identified ways and make it globally accessible. And I think over time, with small baby steps, we're making progress, and we're better implementing and developing these systems, but it's kind of every day, it's a little bit of a battle in terms of which organizations are gonna be there to kind of partner with you and make this an actual reality. Because in theory, it seems like it should be a very feasible task, But unfortunately, the reality can be a very different story, to be quite honest.
Okay, it looks like we have time for about one more question.
Hi, Amy Weinstein. I'm with the Pediatric Brain Tumor Foundation. And first, before I ask my question, I just want to thank you all for being here together on the platform when and I don't know how many of the people in this room have been in the brain tumor world for a long time. I've been here for almost 20 years. And when I started, we never would have seen a panel like this with the FDA, with our pharmaceutical friends and our academics all together trying to tackle the issues to make better treatments for all of our kids. So first of all, thank you. Secondly, I have a question, but it's more of an observation, which is I started in this field on the low-grade side, so the absolute opposite end of DIPGs. The low-grade side, for those of you in the room who don't know, are the kids who have slow-growing tumors. Many of them are cured, but the vast majority live lives that are complicated by adverse medical conditions due to the treatments. So I started on the low-grade side, and I have learned a lot about everything in between DIPG and low-grade. But what we're all talking about are the safety concerns. So we talk about safety concerns for low-grade kids. We talk about safety concerns for high-grade and DIPG kids. And we've started a dialogue with the FDA about endpoints for clinical trials and how endpoints for kids may be different than the standard endpoints that you're using, the FDA is currently using today, to be able to approve a drug or to be able to say this drug is safe. And so I guess my question for the group is, if you think about the whole process in terms of how those endpoints were determined, they were determined based on adult clinical trials. How can we as a group try to help change how the FDA looks at endpoints or safety? It doesn't matter if the child has a DIPG or a PLGA. If we're being told that we can't use this drug because it's unsafe, like that's obviously, to this gentleman here who asked the question before, that's not acceptable to this community. So can you guys help just talk a little bit about how we as a group can help change that?
Yeah, thank you, Amy. I think that's a very challenging question and task. But I think what needs to happen to really change sort of how we think about endpoints, that it's not just overall survival or progression-free survival that we cannot accurately measure currently. It is really that discourse, right? And so we started to have meetings with the FDA, for example, specifically for low-grade gliomas, right? How we can integrate more functional endpoints. And I think it takes discussion, it takes understanding, but it definitely takes the voices of the parents also, right? What is important to them when they think about a successful drug, right? And there's a lot of also quality of life and how a patient feels that we currently don't measure well in our clinical trials. I think we are starting to see a shift where many trials now use, at least as part of reassessments, really looking at quality of life from the parents, but also from the patient-reported outcomes. We are integrating in some studies also more functional endpoints, not as primary endpoint, but at least as secondary endpoint. And I think as we start reiterating around this and learn, I think we will make progress. But it has to be in this dialogue. And I mean, Nicole, please comment on this. But I think we need also the voice from the parents to be heard in these discussions.
Yeah, and I think that that what you say about endpoints is so true. And there is just with respect to patient reported outcomes, there is a division within the OCE, the of patient-focused drug development, that has really made it their task to standardize the assessment of patient-reported outcomes so that it could be used as a regulatory endpoint. We typically say that in order for efficacy to be demonstrated, there needs to be an improvement in the way a patient feels, functions, and survives. And so the way a patient feels is certainly in that. Different types of diseases lend themselves toward different endpoints. And within low-grade glioma, as the example you used, an endpoint of improvement in visual acuity may be an appropriate endpoint for a study that could potentially, result in a regulatory approval, whereas in a disease like DIPG, that may not be the most appropriate endpoint to utilize in a study. For all of these types of endpoints, we need to see the data, and we ask, for that data to be collected through the course of a study, and we use that data and we evaluate that data to see if it supports an improvement in whether the patient feels, functions, or survives. So yes, we do recognize that, and I do think that patient-reported outcomes is an endpoint that has been labeled in some cases for some drugs, but will perhaps be happening more frequently.
And I think the other thing to recognize here is it is very, very hard to collect that data, right? So I think when you talk to a physician, when you talk to a family, they can tell you if a patient is doing well on that medicine or not. But to quantify that in a multi-institutional, multinational clinical trial, to really have consistent data, it's very, very hard. I mean, we start doing this, integrating these functional endpoints and collecting them across institutions. But that's a very hard task, and so far the data has been so variable that I think we still need to think about how we collect this data, what are our endpoints, and what I'm personally very excited about it is if we think about, we heard this earlier, right, sort of this natural language processing, right, these nuances we can, when we read a clinical note, right, we understand, we have a visual how this patient is doing, but capturing this in a clinical trial database is hard. But I think as we start integrating more these AI tools and helping us to really to draw a complete picture of a patient, how a patient is doing, I think hopefully will lend itself to better functional endpoints than just sort of our standard endpoints. But I'm just saying from the initial experience, at least we had in our consortium, it's not trivial. These are not trivial endpoints. So I think we are done with the time. I'm getting the signal over there. So thank you everyone really for joining. We will be around if you have additional questions, and we are really looking very much forward to this ongoing partnership between the regulators, industry, the wonderful families and partnerships here, and enjoy the rest of the summit. Thank you very much.